Crowd is going to increase in the hall. So let's start off for the time being. So this will be the Uro-Oncology session, and for the session I would like to call upon our chairpersons for this current session. Firstly, Dr. P.K. Mishra sir, who is a senior consultant urologist in Amri Hospitals, Kolkata, and Dr. Amit Agarwal sir, who is a senior consultant urologist at Bellevue Hospitals, Kolkata. Welcome, sir. Now I would like to call upon the first speaker of the day. The talk will be on metastatic RCC. Are all IO plus TK pair equal? This will be delivered by Dr. Tanmay Mandal, who is a consultant medical oncologist, Amri Hospitals, Kolkata.
So, very good morning to everyone present, and thanks to this Medica Hospital for this opportunity for giving this talk on metastatic RCC. Are all immuno-oncologic agents and TKI pairs equal? So, small introduction. The renal cell carcinoma is one of the most common form of kidney cancers and accounts for around 74,000 new cases annually in the states. So, 30% patients have a metastatic disease on presentation. And over the last 20 years, the median survival had improved from 1 year in 1990s to it has improved to around 4 years in the recent trials. So presently what we do is the risk stratification based mostly on the IMDC classification. What we do, the MRCC database consortium, which includes the performance status, the time from diagnosis to treatment, anemia, hypercalcemia, neutrophilia and thrombocytosis. Based on this, there are three risk groups, the favorable, the intermediate and poor risk. No risk factors is favorable, intermediate 1 to 2 and above that is poor risk stratification. So the evolution of systemic therapy for advanced or metastatic RCC has evolved from the use of sorafenib earlier in the 2005 to the entry of immuno-oncology from 2017 onwards. We had many approvals in the immunotherapeutic era, and in between there were some VEGF TKIs which were approved like pazopanib and axitinib. So now it's the era of immunotherapy in metastatic RCC. The rationale for use of immuno-oncologic agents in RCC is because RCC is a strongly immunogenic tumors. High numbers of immune cells such as tumor infiltrating lymphocytes are seen, and it's highly infiltrated with CD8 positive T cells, and consequently many therapeutic approaches reinvigorating the T cells present on the tumor immune microenvironment can be done. So for this only novel checkpoint inhibitors are there. So this is just a step that what are the associated with a favorable response to ICIs and associated with unfavorable response. So there are some ERVs, the intratumoral APC, the elevated CD8 T cell infiltration, the increased APM gene expression, PRBM mutation is one of them. These are certain things which are associated with a favorable response to ICI. Basically, there are a plethora of biomarkers, but still till date we don't have a specific biomarker which is suggestive of a good response or a response to immunotherapy based combinations. So like this, there are many biomarkers like the human endogenous retrovirus, or the ERVs, are as normally silenced, but it is upregulated in RCC. And the presence of ERVs has been associated with response to immunotherapy. The similar manner, PDL1, it has not been tested like that, but yes, we see that PDL1 has been also associated with this. Similarly, the RNA expression and microbiome, the tumor microbiome, the PRBM, the polypromo1 mutation has been associated with a response to immunotherapeutic agent. Tumor mutational burden, which is not, the TMB was not associated with PFS or either in the checkmate trials which were done, and sarcomatoid variant is also one of them. So the reason for the development of new agents is that many trials had been done earlier, but the response or the overall survival was not so great with all those, from starting from sorafenib, sunitinib and all those. But with the advent of this newer agents, the immunotherapeutic agents, practice changing trials in the treatment naive setting and also in the second line setting also. So it has been seen that the immunotherapeutic agents like the ipilimumab and nivolumab combination, the pembro-axi, the avelumab-axi, the nivolumab and cabozantinib and the pembro plus lenva, these are the trials which has been practice changing, and it has been seen that there is benefit, there is improvement in the overall survival, PFS, all these. So what's the rationale for combining immuno-oncologic agents with the TKIs? What we see that there is due to the HIF hypoxia inducible factor 2 alpha, they gets upregulated and there is overexpression of PD-L1, so immune checkpoints can act better in that. And another way is VEGF downregulation, suppression of this antigen presentation and T cell priming. So if these VEGF TKIs also can inhibit this, so overall it will lead to overexpression of PD-L1 more, and the tumor will become more immunogenic and the immune checkpoint inhibitors will act much better. So for this reason only the combination of IO and a TKI is preferred, and it has been seen that it might lead to improvement in the effect. So this is only the most common gene alteration is seen in RCC is the VHL gene, which can be altered in 90% of the cases. The major function of this VHL is to regulate the levels of the hypoxia inducible factor alpha, what I said, and upregulation of these leads to more PD-L1 expression, and the anti-PD-L1 can act much better. So the different IO strategies, what has been seen is one is an IO-IO combination which we see now, and the IO plus TKI in the different studies which we saw. So the first line phases, first came the Checkmate 214 in which Nivo plus EP, it was a doublet immunotherapy combination, followed by the Keynote trial of Pembro plus Axi, then the Javelin trial of Avelumab plus Axi, the Checkmate trial of Nivolumab plus Cabozantinib, and lastly in ASCO 2021 the Clear trial of Pembrolizumab plus Lenvatinib. So why axitinib has been preferred? Axitinib is preferred in almost all the IO combinations. It has the short life, it has the shortest half-life of about 6 hours, making it the preferred TKI partner. What we see that the other TKIs have a very long half-life, like cabozantinib has a half-life of around 110 hours, the lenvatinib has a half-life of around 28 hours. And also the selective inhibitor of VEGF receptor, it has a shorter half-life and the manageable safety profile. So we see that the safety TKI has side effects like hypertension, fatigue, hand-foot syndrome. These are the side effects which we see commonly. And the another, it's a highly specific TKI with few off-target effects. So these are all the reasons for why axitinib is the preferred TKI partner with IO in almost all the cases. So then now just we can come to the trials, the 4 trials which we have. The first is the Checkmate trial in which Nivo plus EP was compared with sunitinib in the opposite arm. It was also a phase 3 trial, a phase 3 randomized trial with the primary endpoints of overall response rate, the PFS and OS, and they were subdivided into the different risk groups. So what we see that with the use of doublet TKIs, there at the end of 42 months, the median minimum follow-up of 42 months, the median overall survival was 47% in the doublet arm compared to 26.6 months in the singlet arm. So median survival group was 47 months compared to 26 months, and it was seen that a significant number of patients who experienced complete response either have been able to remain on therapy with no further disease progression or have been able to forego any systemic therapy for years. So next comes the Keynote 426 trial in which the Pembro plus Axi was compared to sunitinib in the opposite arm with the primary endpoints of overall survival and the PFS. In the OS, in the intent to treat population, what we see at the end of 24 months, 74% of the patients were alive, and it was clinically and statistically significant with a hazard ratio of 0.68. So in the intermediate and poor risk also there was a benefit in overall survival, in the PFS, and also in the overall response rate. So what we see that in the Pembro plus Axi arm, the median survival was not reached at the point of cutoff in the overall survival. In the PFS also, what we see that the PFS in the in the immunotherapy arm was 12.7 months compared to 8.3 months in the singlet arm, and an overall response rate of 8% patients had achieved a complete response compared to 2% in the singlet arm. So in the favorable risk group, what we see that the OS and PFS were almost similar in all the groups, so that was not that much statistically significant, although the overall response rate was still better in the favorable risk group also. So median survival was not reached with Pembro-Axi and was 35.7 months with the sunitinib arm. The median PFS was 15.4 months compared to 11.1 months with the comparator arm, and the response rate was close to 60% in the immunotherapy arm, and the median duration of response was around 2 years compared to 15 months in the sunitinib arm. And we see that the common side effects of hypertension, diarrhea, and hypothyroidism were common in both the arms. Next comes the Javelin trial, which compares avelumab axitinib on one arm compared to sunitinib in the other, with the primary endpoints of PFS and OS. So what we see that there is a 31% reduction in the risk of disease progression or death with 5.3 months improvement in the median PFS, with 13.3 months in the avelumab arm and compared to 8 months in the comparator arm. So avelumab and in combination with axitinib also demonstrated superior median PFS in the PD-L1 positive population also, with a 38% reduction in the risk of disease progression or death, and 6.8 months improvement in the median PFS. So here the response rates were also better. What we see that 52.5% had a good response in the doublet arm compared to 27% in the sunitinib alone arm. And irrespective of all the subgroups, they had shown a consistent improvement in the PFS. This is the forest plot. So in patients with large tumor burden and high risk of rapid deterioration, what we see that the choice may be balanced slightly in favor of VEGF TKI IO versus the IO because in the IO combination, what we see there is late separation of the curves in the later phase around after 30 months or something. So rapid early progression affects the overall response rate, but this doesn't happen in the IO plus TKI arm. We have an early separation of the curves which is maintained in the later part also. So for this reason, in a large tumor burden with a high risk of rapid deterioration, a preferred is an IO TKI rather than an IO combination. So avelumab, the results of this, the avelumab had a longer median PFS, consistent maintained PFS nearly twice the objective response rate, with a good faster median time to response and the lower rates of discontinuation and lesser toxicity profile also. Next is the Keynote 9ER trial, which compares the nivolumab plus cabozantinib with sunitinib in the opposite arm with the primary endpoints of PFS. So the progression-free survival was 16.6 months in the doublet arm compared to 8.3 months in the single arm, which was statistically significant with an hazard ratio of 0.5, around 50% improvement. The same thing in the overall survival also, in the nivo plus cabo, the overall survival was not reached in both the arms. So response rate, what we see that the median time to response was 2.8 months in the nivo plus cabo. So there was an early response in that compared to sunitinib, which was 4.2 months. And we also see that the amount of response was around 55% of the patients had a response. So overall response rate favored this nivo plus cabo over the sunitinib across all the subsets, across all the risk groups. So the median survival was not reached in either treatment group at the time point of cutoff. The median PFS for the combination was 16.6 months and the median PFS for sunitinib was 8.3. The hazard ratio for progression was 0.51. The overall survival analysis at the date of cutoff demonstrated longer overall survival for nivo plus cabo in the combination group. The last trial which we have is the Keynote 581, or known as the CLEAR trial, in which Pembro plus lenvatinib was compared to lenvatinib, everolimus and sunitinib. It was a 3-arm study with PFS as the primary endpoint. What we see that there is a improvement in the median PFS with 23.9 months in the combination arm compared to 9.2 months in the sunitinib alone arm, and there is a 61% reduction in the risk of disease progression or death in the doublet arm. So if we see that there is also this is the one cross-trial combination in which we see the overall survival cross-trial combination. Ideally, we should not do a cross-trial combination, but almost all the TKI plus IO had fared better. So the detailed safety and tolerability data across all the regimens were almost well matched. The diarrhea, hypertension, increased lipases, these are the common side effects which we commonly see. So risk group and based analysis also, all the 4 trials had performed well in almost all the settings. So the treatment approaches for progressive disease after first line or more previous lines of therapy, we have the TKIs like cabozantinib, nivolumab. So nivolumab, lenvatinib, everolimus, these are the other choices. So can we cure patient beyond first line combination failure? So there are certain new trials. A rescue strategy with a CTLA4 addition was done to PDL1 in IO plus VEGF TKI pre-treated patients, but it did not induce a complete response. So there is no clear advantage of any combination over the other. The factors which we need to consider while choosing a combination is the treatment goal, lack of a complete response, the toxicity profile, the frequency of infusions. Like the nivolumab, we have the 2 weekly, and pembrolizumab, we have the 3 weekly infusions. The half-life of the TKI, which we said, and efficacy versus the safety profile, and the options available post progression also. So these are the factors which we need to consider while choosing the combination. This is the ESMO guidelines which we see for good risk. The recommended is pembrolizumab plus axitinib or a cabozantinib plus nivolumab is the recommended regimen, and intermediate and poor risk also pembro plus nivo and pembro plus axitinib and cabozantinib plus nivolumab is recommended in those groups also. Although a doublet immunotherapy might be used in the poor risk or the intermediate risk subset. So with this I end my talk, and if any questions I can take.
Wonderful. So elaborate, and at the end we are a little confused with the information overload. I have just one question. In your practice, if you are given a free choice, what will be the combination you will choose?
Sir, I will always prefer to use either a pembro-axi in the or the nivolumab plus cabozantinib in the first line setting if given a choice. Double immunotherapy, it's still I don't think it is used by many. But I would prefer to use a immuno plus TKI combination. It will be a pembro-axi or a nivo plus cabo.
What's the approximate cost?
So the pembrolizumab is actually the patient assistance program wise which we have. It's 2 lakhs per cycle every 3 weekly. And just I think from 1st of August they have launched another patient assistance program. And if you buy 5 cycles, that's 10 lakhs. If you spend, you can get the whole year. So that's the pembrolizumab combination. And axitinib is I think 4 or 5 rupees, which is not that much. But pembrolizumab is too costly. Nivolumab every 2 weekly to 40 milligram dose, so it's 2.4 lakh, and they get 1 cycle with 1 cycle free, so it's like 2.4 lakhs every month. So around
and you can assure the patient to prolong life by say couple of years.
at least it's
Yes.
Generally, RCC we get that patients live longer. It's not so bad like a gallbladder.
And it's applied to all favorable group as well as unfavorable groups.
Yes, preferably to intermediate and poor risk, of course. But yes, it's
favorable groups you don't need to give. favorable groups.
Favorable groups, we can still go ahead with the TKI alone in the favorable group. But yes, for intermediate and poor risk, it has to be this combination.
Any other question?
Nice presentation. We talked about the improvement in quality, life, OS, PFS. What about quality of life?
So in RCC, what we see, they generally don't present in such a bad shape as we see the other malignancies like the gallbladder or they present. So RCC is generally present in a stable condition with a good general performance status. Other than that, if they have a cord compression or severe bone related symptoms, they generally present with a good quality condition. So the quality of life is also well maintained. And with the use of these TKIs and the immunotherapy is quite well tolerated with almost all. And TKI, yes, we need to decrease the dose of the TKI in almost. I think with cabozantinib and nivolumab, generally our Indian patients don't tolerate a 60 mg cabozantinib. We generally prefer to use a 40 mg cabozantinib for all. Axitinib is well tolerated. Sunitinib is again a poorly tolerated drug. The quality of life falls. And pazopanib is also a well tolerated drug. So overall, it's a well maintained quality of life. Although we didn't discuss on the quality of life issues, but yes, that's a major issue which we should discuss for all studies which are presented.
Thank you.
Okay, one more question. What's the status of adjunctive nephrectomy today? Yeah.
So cytoreductive nephrectomy, if the if there are brain mets or if the disease load is too high, means generally we don't recommend for a cytoreductive nephrectomy. But I don't, sir, you can say that how do you fare for cytoreductive nephrectomy?
That's true. There is a lot of confusions in the
Yes, there are a lot of confusions regarding the.
When it is a palliative, it's fine. But then the common sense dictates that if you decrease the tumor load, then probably these immunomodulators will work better. But then that has never been shown in the literature trials.
So in practice, if the patient is not symptomatic, then and the tumor burden is quite high, then we don't do nephrectomies in those cases. But if the tumor burden is more in the kidney and metastatic load is not that high, and patient is symptomatic, like hematuria or pain is there, then we do nephrectomy.
Symptomatic is a different ballgame because there is a purpose is palliation.
Right,
That is quite justified. But if there is no symptoms and there is a resectable kidney tumor with metastasis, that's a situation where it becomes a little confusing. If it is difficult to resect, then surgeons will also not like to touch it. But if it is easily resectable, still resectable, then what should you do?
Sir, but I think one or two small lung mets,
Yeah.
even we don't treat also, means we can keep in observation if an nephrectomy is done. So solitary lung nodule or not a single liver
Right,
met.
so that depends on the metastatic volume basically. If there is a high volume metastatic disease, then there is no need of doing nephrectomy. But if there are only one or two small lung nodules, then maybe we like to operate and
Then probably it's
observe.
better to operate. And in fact, if you look at history, the historical interest in immunotherapies for renal cell carcinomas is because there is reported incidence of spontaneous regression of some solitary metastasis.
Considering that you do a cytoreductive nephrectomy, does that bring in any change in the duration when you can give the immunotherapy or you can start the treatment for a poor or intermediate risk? Like you do a cytoreductive nephrectomy for a symptomatic patient in which it is indicated. So will you start the treatment of immunotherapy giving a certain interval for healing?
So as the patient is declared fit from the surgical side, we
You
can
can
start.
start.
Means it's not a curative setting surgery where we wait for the stitch removal and everything. So even in curative setting also, as long as the patient is declared that, suppose a breast surgery, if the surgeons say that we are okay from our point, no infective focus, we start chemotherapy adjuvant at that point. I think with kidneys also it will be same. But ideally it should be started also as soon, because the systemic control will not be done if it is not started.
So, sir, I just wanted to add, cytoreductive nephrectomy is for good risk patients or intermediate risk with one risk factor with lung only meds. So this is a subgroup analysis of the Carmina trial. Okay. Good risk or intermediate risk with one risk factor with lung only meds. These subgroup did better with cytoreductive surgery. This is only in the TKI era. In the immunotherapy era, there is no data. And in the immunotherapy era, if there is excellent response to immunotherapy, you may consider nephrectomy in the later part, because all have responded, only kidney is remaining. Why don't you remove that? So this also can be done.
Thanks for adding this point actually. Even we have operated one case like that, patient came with the IVC thrombus, inoperable initially. Treatment given, systemic therapy, patient responded well, and then we did nephrectomy later on. You can do that also.
What's the status of locally advanced disease in the lymph node only?
So, locally advanced disease, if it's a node positive disease or if it's poorly differentiated, like a sarcomatoid variant, then there is role of adjuvant pembrolizumab for I think 1 year or 2 years. So we give, there is a role for adjuvant pembrolizumab in that setting, and it's a category 1 recommendation as per the NCCN guideline. And otherwise, I think observation is the another recommendation. Adjuvant sunitinib, I think it's not recommended now that much. With the category of recommendation has gone down. So either it's adjuvant pembrolizumab or it's observation. So there is no point in this recommendation.
So I think we have had a nice discussions. If there is no more questions, you can request Dr. Mandal, Sannindu Mandal, to go ahead with his presentation. That's on the role of difficult nephrectomies, laparoscopic nephrectomies.
Good morning, chairpersons. Good morning, all. We had a good discussion on TKI. My part is different. I'm a surgeon, so I'll take you through the difficult scenarios where we have extended the role of laparoscopy. By definition, a two tumors is a tumor between 10 to 14 centimeters, but then you come across bigger tumors which are 15-20 centimeters, and then laparoscopy and now these robots would help you. The guidelines are very clear. You can try for T2 tumors, but these data restricted to T2 is again T2A, T2B, T2A is less than 10, T2B is more than 10. I will be showing you videos where you have big tumors in the zone of around 20 centimeters. The standard ports, I did not go through with the literature. It would be the most important part is spend some time on your CT. Look at the tumor. This is around 20 centimeter. Right side tumor, upper polar. That's a bad side because the pedicles are generally there in the superior part, and that makes life difficult. But then as you start picking these cases, you realize the principle of surgery remains the same. This is my mass. The colon you can see. What I am using is actually a 3D Olympus set. Thunderbeat on my right hand and a grasping forceps, and this is all you need. You do not need a right angle, you do not need robust things. The blue, these are the neovascularizations you will come up. These are the neovascularizations. Big tumors would pick up neovascularization from every aspect. So the clips you see are the neovascularizations from the source. So you have to be gentle and you have to go ahead with it. There's generally not a lot of trouble. We pick it up from the psoas muscle. This is your psoas muscle. You pick it up, you go in the plane below it. The ureterogonadal complexes are generally tackled up front, but we have been doing radical nephrectomies for the last 7 years, so we have been a sort of expert thing. So we generally now go in and tackle the pedicle first for such big tumors. So as you can see, it's the cauterization being done. There are a lot of those neovascularizations, those angry vessels over it. The problem is once these veins start bleeding, that's very difficult because neovascularization veins and the normal veins are different, being that neovascularization veins are even thinner. So you have to make sure you are in the right plane. This is the duodenum on the right side, and you are going in the plane between the duodenum and the kidney, creating those planes. What tumor does is, as long as the tumors are within the kidney, the natural mechanism of things are that they just push away things. So you get a very good plane in that region. So things generally go on smoothly. The total operative time is in the zone of an hour or 2 to 90 minutes. But you have to be careful at times, going very slowly, because duodenum is a non-forgiving organ. Any injury to the duodenum can have a catastrophic result. So we go slow when we are close to the duodenum. So this is part 1. The next part is, you catch hold of your gonadal vessel, you know your landmarks. You have to get your IVCs. As we say in a thyroid operation, the best way to avoid a nerve injury is to locate your nerve. Similarly, for any radical nephrectomies, you can see it, the renal mass, the renal vein can be seen. Pick up your IVC. On the right side, you need to see the IVC. IVC should be always in your field. Let us not be blinded with it. So this is the gonadal vein, and on the side of it is the IVC. We will now just go in a plane lateral to the IVC and pick up every structure, and that's the plane that will take you through your renal artery and the renal vein. So this is what we are walking at the lateral border of the IVC. So this is your IVC. So we have created the inferior window whereby your kidney, your ureter, all are picked up. So this is just that inferior window which gets created. Inferior window is the part which is below the renal artery and vein, and the superior window is the part which is above it. And you just need to create these two windows. Once these windows are created, even if you are not able to find the artery or the vein separately, you can use your stapler. So now we have the renal vein, the arteries have been cleared. The CT had given me information that I am coming across 2 renal arteries. So I have isolated my 2 renal arteries. Generally the concordance between a very good CT and intraoperative is around 95%. Yes, you come across surprises in 5% of the cases, but generally they are concordant. So a very well done CT helps you. Once the arteries are tackled, you are very much satisfied that your kidney and the vascular tumor is not being supplied by any more blood. You now come to switch over to the superior window. By that I mean the dissection between the upper border of the renal vein till the psoas. So once that gets cleared, there is nothing to worry. And for such big tumors, if you get a plane between your adrenal, preserve it. The guideline says, for as far as the preservation of adrenals are concerned, if you see adrenal invasion on CT, then only try to remove it, otherwise you can spare it. In this particular case, we are not sparing the adrenal because this was almost a 20 centimeter tumor. So now see, what are you left with is only some flimsy tissues behind the vein. The tumor is now only attached to the renal vein. The vein is quite big. Your largest clip is the XL clip, which will not accommodate, so you need a stapler, a vascular stapler. Stapler takes care of these large veins which you typically encounter in these large tumors, and you are done with your nephrectomy. And as you can see, this is almost a 20 centimeter tumor. So yes, things always don't go well. The first case I showed you was a very big tumor which went off very nicely. Now I'll show you in these 3 videos when things do not go well. This is another big tumor, right side, 15 to 20 centimeters. The common problem you will come across is arterial injury and a venous injury, and I will just take you through how to manage it. This is again a CT of a big tumor you come across, lot of neovascularizations, simple dissections being going on. We have come across a neovascularization vein. We are just clipping it. At times these veins do not seal with your vessel sealer, so you have just clipped it. And then, as you see, as I try to cut it, this is the worst nightmare you would like to see as a surgeon. As you cut the neovascularization vein, what happens? This, a spurt of blood, and you see nothing. Normally, earlier, as the reflux goes in, you would convert it to open. But off late, yes, we have gone through phases. Off late, what we do is a gauze piece comes in. As long as the anesthetist tells you that the patient is hemodynamically stable, even for renal arteries which have been accidentally cut open, you can manage it laparoscopically. A large gauze piece goes in. Gauze piece is always a savior. What actually happens is, once you put in the gauze piece in the zone of the renal artery and you try to catch in that zone, the artery goes into spasm, and that is what we have learned after we started doing these donor nephrectomies. As you start handling in that zone of the artery goes into spasm, and now you can see the same patient, the bleed has almost controlled, and it takes you 15 minutes to do that. Yes, the field deteriorates, but you can tackle it. We then realized there was a small renal artery which was just behind that neovascularization, and that bled, and we could easily tackle it. Yes, but that takes time, but you will learn. So the first thing is, do not panic. You should believe yourself that you can do it, and that there should not be any compromise to the patient. So if your patient is still hemodynamically stable, your anesthetist is comfortable, the loss in this case was around 500 ml, but we could manage it laparoscopically. And then the final normal routine steps proceeded. We could take care of the stapler, vein with the stapler. In the second case, again, you would come across surprises. We go through the CT spending 15 minutes. We could clearly see there was one renal artery, but the problem was the renal artery close to the kidney was dividing. So probably that was what we missed it. As you can see, the renal artery, if you go very close to the kidney, it was dividing. CT angios are routine for us. We go for these as we have it at our center. So again, a left-sided nephrectomy is being done. You can see the pulsation of the artery. So you know where your artery is. This is your vein. So this is my artery, and very easily things are proceeding. As a matter of fact, in my center, my third years do this radical nephrectomy, and this is one of the videos where my third years were doing it, and it's appeared absolutely normal till this happened, and then you realize there's an aberrant artery which is below. So there's nothing to worry. You can hold it with your grasper, call for help. The gauze piece goes in. The gauze piece has really been a savior for us laparoscopic surgeons. It always goes in and it always helps you out. And you are able to control things. The left instrument always stays back. You can always put in an extra port for the suctioning. We do the standard radical nephrectomy with a 3-port technique, where one is the camera and the other 2 are the surgeon's working port. We do not take a 4th port. We do not routinely put drain unless and until it was a big tumor or there was a lot of bleeding. And finally you can see it got tackled with the clip. And then you take care of the main renal vein and the artery. So this was yet another big RCC. Again, it's not the artery that only bleeds. The neovascularization will create a lot of trouble for you. This was another big tumor with a lot of neovascularization. And see, we have the vein in front, just behind is the artery, we are dissecting it. But all of a sudden, everything looks fine. But all of a sudden, you don't see what is going on behind. And as you walk, as you see a small neovascularization vein and you try to tackle it as you do normally, but just hold it and it starts bleeding. And these neovascularization veins are very unforgiving. They would not give you time to respond. So again, gauze piece, they help you. So gauze piece goes in and you are managed. So these sort of accidents would happen, but the message would be, do not worry, this is what normally happens, would happen with everybody. Take your time and then you would be able to go in and proceed. This is the artery which is getting clipped. In the meantime, we took a suction port and somebody was pressing on that gauze piece. That gauze piece remained there and we could take care of our artery, and we could take care of the vein. Once the arteries are taken care, the draining goes off. So you don't come across that much of bleeding that you need to convert it. And finally, the vein is clipped and cut, and similarly is the artery. So the message basically that I want to give you is, even for large T2 tumors, you can go ahead with laparoscopic radical nephrectomies. Yes, you would come across difficulties, but the difficulties can be managed laparoscopically. So these are our data over the last 7 years. This is basically for large tumors, and in most of these cases, we have been able to complete it laparoscopically. So almost 63 cases, 2 or 3 cases needed opening up, and these were the cases which were very early in our learning curve. And again, then you have your hand port. That also is quite easy. The specimen retrieval site, just make an incision enough, put in your hand. You can use a second glove to seal the pneumoperitoneum, and the hand goes in. Thank you.
Excellent disposition. So what we have learned is we need experience, we need the right kind of equipment. I think from your center only there is a recent publications which shows that can a trans-abdominal ultrasound, I mean laparoscopic ultrasound.
Yeah. So these are the exactly cases where we tell, because you do not know what happens. The tumor dynamics changes the arterial and the venous positions. So when you have a tumor on the lower pole, it tends to push it up. What we would personally like would be a tumor on the lower pole which pushes it up, so that my pedicle area stays virgin. I'll straight away go and tackle that. In those difficult cases, we have an intraoperative ultrasound. Actually, you need it for your partial nephrectomy, but I believe most of the good centers would have it. Take your intraoperative ultrasound and put it in that area after you mobilize your colon. You can come across your artery and vein, and that helps you deciding it. And yes, I mean, if you really want to get your artery and veins separately, fair enough. Otherwise, that classical description where we are taught in the textbook that if you clip the artery and the vein, staple them, it leads to AV fistula formations, all that. We have never come across those things. I think we would have used more than 50 cases where we have used a stapler, and we have not come across any case where a AV fistula forms. So for these difficult cases, create your inferior window, create your superior window, just apply stapler, you should be successful.
I believe that's a nice learning impact when there is vessels are encased in the mass of lymphatics and you are not able to, you have the option of slowly dissecting, but you can become a little more bold and probably complete the surgery.
And for this bleeding, do not panic. A small amount of bleed is generally managed. Our anesthetists are quite encouraging. They say 500 to 800 ml of blood loss can be easily managed by a patient who is 60 plus hemodynamically stable. Till then you can go ahead. At a time when they say no, it's deteriorating, then you need to open it up.
That's true. So any other question? Or else we will wind up. There has been constant reminder from the organizers to hasten up. So if there is, so you have if this co-chair wants to ask you a question. If there is accidental IVC injury.
So IVC injuries are not very forgiving, because the vein is very thin, it bleeds very much. So again, what you have is you have a Satinsky. If you have a 10 mm port in situ, at times you will be able to catch hold of it. Otherwise you have to open it up. IVC injuries are not forgiving. You have to open it up. But then with the experience of now for the IVC thrombus also, we are doing laparoscopy. We are taking the control over the IVC. We are taking a superior control, opposite side renal vein control, and the inferior control. But with these maneuvers, you get confidence that even if it bleeds, you would be able to put in a Satinsky and take care of it.
You use rescue stitch that described for.
We were keeping it earlier, sir, but now we never required it. So the confidence grows, so you do not keep it. But yes, it's always better to keep it. A 5-0 or a 4-0 proline is always better to be there.
The central message is experience.
As you grow up, you would do it. But what I would say is laparoscopy has revolutionized the surgery. If you ask me, open surgery is more difficult than laparoscopy, because you see better, things are magnified, things are under your control, and you feel that you are able to do it. So yes, open are more difficult than lab, and I think robots have simplified it.
Totally agree. So,
Thank you, sir. It was a nice presentation.
Thank you,
Yeah,
Dr.
looking at your surgery, I don't feel you require robot. I mean, you are doing good job in laparoscopy.
Yeah, like it said, na, you change your adversity into an opportunity. We were not getting a robot, so we never thought we should hold back ourselves. We are doing every case possible as a robotic surgeon, which you can do. We are trying to do it laparoscopically. Thank you. Thank you all. Thank you, Chairperson.
Thank you, sir. Now we'll proceed with the first panel. Panel will be on TMT in bladder. With the moderator for the session will be Dr. Thiranjan Basu, sir, who is a senior consultant radiation oncologist at HCG Cancer Center, Borivali, Mumbai. The panelists for the session will be Dr. Arijit Sen, consultant radiation oncologist, Narayana Super Speciality Hospital, Howrah. Dr. Pradeep Mandal, sir, consultant medical oncologist, Medica Cancer Hospital, Kolkata. Dr. Siddharth Kumar, consultant urologist, Medica Hospital, Ranchi. And Dr. P.K. Mishra, sir, senior consultant urologist, Amri Hospital, Kolkata. Thank you.
Okay, yeah. So we have, if I'm right, we have two urologists, urosurgeons, one medical oncologist, one radiation oncologist. I'll take liberty of, with this small gathering, asking Abhay and other people in the crowd questions. So it's rare to conduct a panel on TMT in bladder cancer as radiation oncologist. So let's see how interactive we can make it finally. Okay, so if we look at the overall management of MIBC, be it across the Atlantic, be it the European or American guideline, this is what you come across. So even on a large scale across the globe, it's still TMT is not able to pick up what it should have been. Why, we will try to see in the panel discussion. So let me start by asking all my panelists, what we mean by, in simple lines, trimodality therapy in muscle invasive bladder cancer. So we'll start from maybe the far end.
Trimodality therapy means the triple modality. First is the surgical resection of the bladder tumor, which should be the visibly complete turbidity. Second, followed by the radiotherapy and chemotherapy, preferably concurrently.
Okay, so from our surgeon colleagues, so anything different from this?
So yeah, I agree that the trimodality therapy includes all the three modalities. Firstly, it should be a maximal TURBT. It should be a visibly complete resection and going as far to the extravesical fat if needed. And there should be radiotherapy combined with the chemotherapy modality as well. And the selection should be very specific.
I'll come to that. So, do we have randomized evidence? That is what, especially as radiation oncology, we are often been asked, that do we have randomized evidence? So, do we have randomized evidence between a radical cystectomy versus a bladder preservation approach?
So, yeah, so it's very difficult because to perform a randomized trial to select patients of these very rare tumors. So that's why that probably the randomized evidence is not there for this sort of disease, that trimodality versus that standard of neoadjuvant chemotherapy followed by radical cystectomy. So till now the randomized phase 3 trial is not there comparing this two.
So very true, and very surprisingly, this was about 12-13 years back in UK. They started a spare protocol.
So that is recruitment was very less, so that's why it stopped.
Yes. So in a so-called civilized nation where people follow standard guidelines. You have government who is dictating that what should be the nationwide protocol. The trial had a bit complicated design of pre-selection between RC and TMT, doing a neoadjuvant, checking response both local and imaging wise, and then trying to proceed good responders versus poor responders. Now, this was published about 10-12 years back, and though it was not meant to, just meant to record the adverse event, the adverse events seem to be more in the non-operative arms. The reasons are manifold, and this was followed by a very nice editorial in BJUI. This is also about 10 years back. That what lessons we have learned. We have learned the lessons related to poor recruitment, a non-compliance to protocol in a country like UK. There are a lot of treatment complexities which are added, and multiple people are involved in this. So any comment from our surgeon colleague side that why this has failed?
One, basically there are two clinical scenarios where we will recruit patients for this multimodal therapy. One is a situation where the patient is not fit for surgery or not willing for surgery. That's pretty easy to recruit. But in the other scenario, when there is a localized muscle invasive tumor and you are giving him an option that you can preserve your bladder and pelvic. There are clinical situations where it is really painful. I'll give you an example of my clinical experience. There was a patient who had a muscle invasive tumor, and I advised him for radical cystectomy. On the radical cystectomy specimen, there is no evidence of tumor. So this do occur.
This is after NAC.
So if that can occur, in that patient probably would have immensely benefited by a multimodal. But how do we really select those patients? That's probably the crux of this problem.
So I have a question to Pradeep, to you, that we always see this is traditionally true for lung, traditionally true for prostate, the same is also in bladder, that we say to patients who are not so fit and all, if they're not so fit for RCIC, are they fit for a bladder preservation protocol in cisplatin?
Absolutely not. They are not fit, and those are the reasons why bringing less popularity, less acceptance for these therapies.
Okay.
But if you can rightly select the early cases, probably this will be the most desirable option for treatment. But we somehow we are not in a position to confidently select our patients because of lack of data and lack of experience.
What I would like to add to sir, we have got very nice modalities of staging the bladder cancer right now, and we have come up with a very good VIRAD system as well on the MRI. So specific location in which the tumor is specifically located to the superficial part of the muscularis propria, and it is localized without any diffuse changes on obvious endoscopy of having a multifocal disease or a CIS changes. This modality can prove to be a game changer.
MRIs probably will be able to tell us more accurately.
So I have a point in that, we'll come to that. So then about 10-13 years later, these are two whatever best available resource we can have related to TMT. Since we don't have a randomized trial, and it doesn't look like we'll ever have a randomized trial between these, so there's one comparative effectiveness analysis trying to do a propensity score match. If you look at the three curves carefully, the A is comorbs present, moderate, severe, B is the nodal status, and C is the type of modality. So there is no difference between the type of modality. It is also not dependent on age or performance status for that matter. Similarly, in Lancet, this was published last month of again a sort of a multi-institutional propensity score. So these were the important points. Most of the patients had tumor less than 7 cm, no or only unilateral hydronephrosis, no multifocal CIS. They kept a very nice primary endpoint of metastasis-free survival, trying to do a propensity score matching, good follow-up, equivalent 5-year MFS in either of the groups, and equivalent cancer-specific survival in either of the groups. So the very important interpretation is the bladder preservation technique is not an option for non-surgery decline, poor performance status. So this, we should try to bury these thoughts as we go along. This is not a modality only suited for not so well performing patients. Now, then I have to ask so do you have any specific typical indications where as neurosurgeons you would send to us that, okay, this patient is good for preservation? Then I'll ask the reverse.
I believe if we have a patient who has got, just gone to the blood pressure muscles, not gone beyond, and maybe a redo TURBTs has also proved as negative, those are the patients which you can very confidently put for radiation therapy.
Yeah, I would agree. And again, presence of hydronephrosis is an important consideration for me. Also, while on endoscopy, I would like to see for the carcinoma in situ changes. It should not be very extensive and preferably non-exentional. And nodal status obviously should be negative.
We'll come to nodal status. I have a point for that separate. Arjit, your side, you would send to, say the patient has walked onto you, you want to spare our bladder, but
first,
you would proactively send to the surgeons.
First we have to check is the bladder is what sparing or not. So is it retained the bladder capacity? It's adequate renal function and there is no hydronephrosis. And tumor staging wise, it will classically will be T2, T3 will be classical for the TMT approach in node negative without any extensive carcinoma in situ.
Okay, say we decided in a joint clinic that we are going for bladder preservation, since that's the topic of the panel discussion. So the TURBT is planned, of course, and then we'll go ahead. So in specific, these 2 points, is there a specific role of MR or PET? Most of the time, because we'll have a scopy, biopsy, a CT urography, or maybe just a CT with that. Is there a specific role of MRI and PET pre-TURBT while deciding for bladder preservation?
MRI, yes, there is a role because in the recent trials we have seen there is comparison between the whole bladder boost versus the gross tumor boost.
Yes.
So to delineate the gross tumor at the baseline, so we need a baseline MRI as a perspective radiation oncologist. And PET CT we can do for the metastatic work.
Okay, now the gross tumor point also will come. Ideally, there should not be any gross tumor except for certain scenarios, so we'll come to that. Now, Pradeep, is there a role of molecular classification as it is coming up like every site in selecting cases for bladder preservation?
Yeah, so till now that genomic assays and all these things is still not validated much. So probably that in my clinical practice I will not include this as an determining factors. And probably this is in till that clinical trial setting. So outside clinical trial I will not do this molecular testings for deciding factors of bladder preservation.
Okay, so these are the classical indications, the preferred or ideal, the less than ideal, and the so-called contraindications. So we'll see as in clinical scenarios what we, and these are more or less the points we spoke in panel. These are certain clinical features also, as because we don't have randomized evidence from large single or multi-institutional series. These are the important points. As we discussed, the tumor diameter, the more it increases, the less will be the effectiveness, the performance status, the cisplatin eligible versus non-eligible, and the tumor diameter also definitely has a role to play. Now, this is what is it a recent coming up of this was an EAU platinum paper on bladder molecular classification. As we go along from luminal to other rarer basal and neuroendocrine type, the chances of failure increases. Probably going forward in future, selecting bladder preservation, this will start playing a role. The more you have the basal and neuroendocrine and poorer types, they maybe will be a better candidate even on a lesser T size for a surgical modality than bladder preservation. Now, we have very nicely done EAU guidelines about what we discussed related to imaging. Yes, a CT and CT urography remains a standard of care. PET may be only for the distant staging. There is no role for local staging in a bladder. So, I will ask our surgical colleagues. So, it is done a TURBT. How important to do a complete TURBT if the patient is going for bladder preservation? And where, in which scenarios we are not able to do complete?
I believe it's mandatory to have a complete
Yes, sir.
TURBT before you can put a patient for primary radiotherapy, because that's the easiest way of removing the tumor if it is possible to do. But then, having said that, if the invasion is too deep outside, typically
Yes, sir. Yes.
grade C levels, it has gone outside the confines of the bladder muscles, then it's difficult to do a TURBT, and especially the location also. If the location is in the fundus, you can end in perforations. So in those situations, it's probably not possible to do a radical TURBT kind
Yes.
of thing. So otherwise, it's probably, if you can do that, that's probably an advantage too.
So that's a very important point. For bladder preservation, once we are planning with then eventually radiation and chemo, a complete TURBT is the need. Yes, that is the exact scenario in extravesical disease where, and that is what you're generally what you're trying to say. Because otherwise we should not be having any gross tumor. So any concerns about will you choose an open, a laser or a robotic? Or any difference in either?
No, laser enucleations, laser dissections are possible, which are located in the fixed part of the bladder, in the base or in the lateral walls, but in the fundus it is difficult to do a laser resection. The TURBT, the standard monopolar or bipolar is still a choice.
Yes.
But if it is, having said that, if it is located in a situation where it is easy to remove en bulk with the laser, that should be much easier, more hemostatic, and probably will cause less dissemination of the tumor cells inside the bladder.
So I agree with sir. If the tumor is located at the favorable position and we have already characterized the tumor space, especially an imaging such as an MRI, and we believe that it is in the superficial part, then a laser TURBT can be very good. Otherwise, a standard monopolar or a bipolar TURBT would suffice.
So Abhay, king of robotics, will you do robotics in this? In some situations. So I was SogoCon yesterday, so we had a session on this only, laser versus open versus robotic. I guess there are randomized trials also between open and robotic, and nothing much changes relative to TURBT, right?
What's robotic TURBT?
Yes, those are mainly for cystectomies, yes. Those are mainly for cystectomies. So, any role of partial cystectomy as part of bladder preservation? Say the patient is hell-bent that we want to retain. Are there any indications of that?
Can I answer?
Yeah.
See, I have some experience of doing partial cystectomies in these kind of patients. But the cornerstone is the patient selection. Yes. So solid tumor, small tumor, no CIS, patient is willing for, and blood is kind of, again, blood is salvageable, right?
Yes.
So good capacity bladder, you can do partial cystectomy. But yeah, the patient needs regular cystoscopy and regular follow-up, and the patient must be counseled that if there is a recurrence, he may require radical cystectomy. So in fact, in my practice, I have done again partial cystectomy. Patient received adjuvant chemotherapy, and follow-up here got recurrence, and I then had to do a radical cystectomy.
Yes.
But yeah, in select cases, you can do.
Yeah, in select cases, so that those are the actually from MD Anderson and MS cases, they have some partial cystectomy guideline. But somehow there is no data still between the two to prove of oncological outcome related. But yes, in select cases, maybe there is a role, it's still quite maybe. We can skip this, skip the cystectomy part. This is what the partial cystectomy data, so typically solitary tumor and where you can get a 2 centimeter margin, no CIS, good bladder function, and no ureteral implantation requirement if it is there, if it is not there. Maybe it is something to look for in future. So I'll come to the radiation oncological leak. So the patient has decided TURBT done, we are going to do a bladder preservation. So very quickly, what dose, what technique, is there a role of simultaneous integrated boost? If you have gross disease, like we discussed, if there is an extravesical component, maybe TURBT will have some residual post TURBT.
Talking one by one, first, the RT dose, the total equity should be 60 to 64 grade. And if you see the schedule, the RTOG group mainly use the split course RT.
Yes.
And the European the continuous course RT.
So what you will do? What you will do? Forget about that.
Continuous
Is it
course-
really feasible to do split course in our setup?
Continuous course RT is preferable because tumors in GCC it is a highly repopulation starts
Yes.
after 5 weeks, so treatment should be completed as soon as possible. So technique should be, if we have the adaptive facilities, treatment will be the image guided radiotherapy, and the dose, the fractionation schedule should be 50 grain 20 fraction over 4 weeks. Because if you see the IBD meta-analysis in the PC2001 and the Beacon trial, there is non-inferior, hypofraction is non-inferior to the conventional fractionation. And if you see the continuing guideline, so there is in BC2001 trial, there is 2/2 factorial randomization between the whole bladder boost versus the partial bladder boost. In partial bladder, there is no decrease in the acute toxicities. So in bladder, filling is different, reproducibility is different, difficult in day-to-day practice. So I will prefer the whole bladder irradiation.
Yeah, even EstroAcrop has a guideline on bladder contouring, so it is still. So will you include prostate in the volume? When you will include, when you will not
If
include?
there is clinically or radiologically prostate invasion, so I will include the whole prostate.
So similarly, I'll ask for surgeons. Once you're doing TURBT surgery, is there a role of a blind prostate biopsy or some clinical scenario where you have to biopsy that?
If there is a suspicion of cancer in situ, CA in situ, we do prostate biopsies, mucosal biopsy from the prostatic tumors, along with random biopsies from the bladder mass. Otherwise, if there is the tumor is away and there is no evidence of cancer in situ, we don't do it. I don't know, is there any guideline for that?
No, this is exactly like this mentioned. So you planned a daily image guidance.
Yes. And regarding contouring, one point also, if there
Just
is
one question, do you give a boost to the area of tumor by image guidance or something, or you just radiate the whole bladder?
no, I will radiate the whole bladder because classically TURBT is visibly complete. So there is no
So
glossy.
that was the point we're discussing. If there's extravesical component where TURBT is not complete, then you have to mark that area maybe as your GTB and try to do a simultaneous integrated boost. We have Indian data from Dr. Vedang, very, very well, long follow-up now. So yes, there's a role of that.
And regarding the contouring the urethra, if there is primary index tumor at the bladder neck, so we should include the initial 1 to 1.5 cm of the prostatic urethra also. And the nodal irradiation, there is doubt.
No, I'll come to that. Let's complete the IGL. So Manu, you do Euro. So any comment on PTV? Because that is the most challenge in treating bladder, and how will you do it?
So it depends upon the machine, the facility which we have in the institute. So if we have an adaptive setting, like we usually treat in tomotherapy, in that case we can give multiple volumes and do different plans based upon the volume. So what we usually do is we take an empty bladder as well as a full bladder scans and see how much, like, and we create another additional volume so that if it matches in between anywhere, depending on our daily protocol, whichever is matching, we can use that plan and treat.
So we have about 10 years back this plan of the day data from Dr. Vedang. So what we do, because I also don't work on a Tomo setup that originally started from Tomo. What I do is I create two PTVs at least with different margins. See plan in the both. The higher margin, if they meet up the dose constraint, then you are safe. And try and see your image daily. The more, the lesser margin you are able to match. But yes, even however fast your machine is, in 2 or 3 minutes, even if it's taking, there's a risk of bladder overfilling. So that, I guess, is the most critical part of bladder preservation protocol. One should not over-treat or under-treat, and that is why we probably don't get proper result of it. So Arjit, will you include node?
If you do the BC2001 trial, there is only bladder artery.
Yes.
And isolated pelvic nodal recurrence was less than 10%. So I will prefer to treat bladder only.
Bladder only. Yeah, the protocol is that until you really have node positive. And if patient is not able to receive chemo, is there a role of altered fractionation?
Accelerated fractionation tried with hyperfraction twice daily, but there is increase.
None of us will be able to do hyperfractionation. Forget about that. Give us practical answer. Will you do hypofractionated? And how much hypo then will you do?
with moderate hyperfractionation in 55 brain 20 fraction, or SBRT data is coming,
Yes.
36 brain 6 fraction weekly.
Yes, Sayan, will you start that?
Not yet. Probably I'll wait for some more long
So
data.
the bladder SBRT data is from Robert Hoodard, who is the same person who has done all more or less comparative effectiveness analysis. Yes, so we'll really have to wait for that. Now, these are the guidelines. It is given very nicely as in Green Journal about GTV, CTV and PTV what we discussed. We have in bladder a very good Indian data from Dr. Vedant, started with the plan of the day, then the clinical outcome of this SIB, which is a bit of a dose escalation to the suspected gross, and then also the role of adaptive radiation for a long-term outcome with this dose escalation. It is safe, it is effective, you have to follow standard guideline and a standard imaging protocol. So that is the take-home message from this. This we can skip. This is for the dose. So to now Pradeep. So this is planned as a bladder preservation receiving concurrent treatment. Is planned or anything else?
So that most of the time, yes, that most of the data is cisplatin 5-FU based regimen. If patient is not eligible for cisplatin based regimen, even 5-FU mitomycin is also tried. Even paclitaxel tried in different protocols, different trials. In most of the times in my clinical practice, in currently, I am giving concurrent gemcitabine, single agent gemcitabine that is well tolerated, and I am using 300 milligram per meter square dosing weekly protocol that is well tolerated in a different RTOG trial also. That is, though in some trials that gem has been tried, it is well tolerated and it has shown then good radiosensitizing effects. And most important is the tolerability, because in concurrent CTI, the most of the patients are elderly, and we have seen that even with cisplatin, not only that renal toxicities, that we have seen lots of neutropenia also in cisplatin. Though gemcitabine causes some myelosuppression, but in 300 mg per meter square, mostly we face anemia. So I am more I'm happy with gemcitabine, using gemcitabine as a concurrent chemo regimen in this type of protocol.
So there's one RTOG trial also going on with comparing gem versus a bit complicated regime of radiation with a dual agent also.
Yes.
There's a single arm trial also from the Chetak group of cis-gem, so probably we'll await result of this in bladder preservation. So any role of concurrent immuno, since you guys are in everywhere and everything.
Yes.
So abundant cisplatin, it is toxic. Abundant probably radiation and just do immuno. Is there a role in that?
So till now that different clinical trials, so probably it's still in clinical trial setting, that in clinical practice we have not adopted immunotherapy as a concurrent regimen. And even for that this setting, that as an adjuvant later on immuno, so till now we have not adopted into our clinical practice.
Any difference that you have observed in the radiosensitizing effect of various chemotherapy agents, like the response to say mitomycin with the 5-fluorouracil has got a better radiosensitizing property than possibly cisplatin. So any difference in the treatment outcomes regarding the
Of course, that our clinical experience from different other tumors also, that cisplatin has definitely has a very good radiosensitizing effect. So only issue is that yes, mitomycin also. Problem with mitomycin is that probably that neutropenia is an issue with mitomycin, and that 5-FU is difficult, that we have to use 5-FU support, that isn't more that infusion isn't problematic. So 5-FU regimens we try to avoid in this type of protocol. So sensitization that we have seen in GI also, in pancreas also we have used gemcitabine as a sensitizing radiosensitizers, and in image also that we use gemcitabine as a radiosensitizer in even pancreas and GI malignancies, gallbladder where records. So we are happy with gemcitabine as a radiosensitizer. So and it's well tolerated. So most of the times we use this radiosensitizer.
So to all my panelists, so let's say the patient is node positive in baseline, muscle invasive, and they want to do a bladder preservation. So how the protocol should be, or are we ready to do it?
Recently, we have a retrospective analysis. So they have taken the node positive cases and selected initially 2 to 3 cycles of NSCT. If they are performing
So
well,
that was the spare trial protocol also, without even node positive in that.
if there is a stable disease or even partial response, they are taken for radical treatment. That's the TMT. And otherwise, if there is progression, they are taken as a palliative treatment. The analysis showed that if we taken as radically, there is improvement in OS and PFS in node positive cases also.
So our surgeon.
I would add to that. Again, in node positive cases, we would definitely like to go forward with the new adjuvant,
Yes,
considering it
that-
to be
that
a
is undoubtedly, yes.
systemic disease. And again, visible TURBT. And if the patient is very adamant that they have to go for a trimodal therapy, then only we give that option. Otherwise, it is better.
So otherwise, surgeons give only option as radical cystectomy.
It is better.
So where do you have strong data that yes, radical cystectomy will have no
Better.
local failure, or the metastasis-free survival also is better in that? Do you have data on that?
Yes, sir. Would like to.
Yes, Owen.
Real-time data will never come. As a surgeon, I would be biased towards surgery, and a medical oncologist would be biased towards it.
I'm radiation oncologist, so we'll be
Yeah.
biased towards
Yeah.
bladder preservation.
Yeah, but if you really ask yourself, or if I am allowed to ask myself, if I have bladder cancer, do I undergo a TMT or a RCIC? With the results currently available, let us not get into RCTs. RCTs have their own problems.
No, we'll never have an RCT in this.
Yes.
We will never have.
So these would be more of an individualized.
Yes.
It would depend upon whether the patient has an access to healthcare things. TMT is easily said and done. You have to be in a strong follow-up. And this is very much inherently absent to our patient subset. Once they feel they are doing well, they will not come up. So these would be the issues which needs to be tackled. Yes, for an insured patient, I would go for a TMT, but for a non-insured patient, RCI is the singlest option. We should probably.
See, we are doing the largest volume of cystectomies in SWAT. But still I feel maybe we are far away from the right treatment. Even if you do cystectomies, 5 years survival is hardly 65-70%.
Yes.
So maybe still we are looking for the right treatment. And patients who can find non-positive disease, he is not going to benefit from this kind of surgeries or life-changing surgeries. So still the options given to the patient, and depending on the response to NCT, if there is stable disease, options are there, can be considered cystectomies or maybe blood preservation.
So can we take from this the message that even in N positive MIBC there is a chance of bladder preservation, right? At least we are able to push through our surgical friends that okay, we still have a role in this.
I would definitely agree to it. There is a chance of bladder
So I note
preservation.
this point.
Yeah, so there is a chance of bladder preservation. Again, but then what Sir said, there has to be a very stringent follow-up. The accessibility should be good, and obviously we need to give that option since the technology has evolved. So we need to give that option.
Okay, so move.
Can I put a question?
Yes,
to-
sure, sir.
I mean, pardon my ignorance. Is this done always concurrently, and there is a role of sequencing therapies with radiotherapy and chemotherapy?
Mostly concurrent. That data is mostly concurrent. Because if patient is not at all fit for that concurrent chemoradiotherapy, so that is basically that blood.
Side effects we really see in practice.
Oh.
Yes, Arijit, you can speak.
There are great rate of cystitis and grade 2, grade 3 cystitis are there, and if there is concurrent chemotherapy, there is grade 2, grade 3 neutropenia, and on the clinical trials also there is no grade 4 or grade 5 toxicities. So this is well tolerated TMTs.
Fatigue, mostly in gemcitabine, that most of the patients complains of fatigue and OPD basis, that daycare basis.
Actually, all with a proper IGRT in place, if the planning is done well, sir, then in today's time, any pelvic malignancies are quite well tolerated. Especially with IMRTV, the GI side effects have gone down tremendously. So it is quite a well tolerated. So this is what we were talking about. This just came some days back in seminars with Redonk, and Dr. Vedam also is a part of it, of the node positive. There's some sort of guideline type. Yes, the changes, there's a definite change in staging. The clinical or pathological nodes as once thought to be metastatic bladder is no more thought about that. If it's in the pelvis or just away up to lower paraortic. Systemic, there can be, or all options can be true till we have more data. Systemic chemo alone, chemo followed by an RCIC, followed by evaluation, and some incorporation of immune checkpoint inhibitors. Now, I'll come to the last point before we close and take everybody's opinion of cost. So this was done in JAMA surgery somehow, and in their analysis between a radical cystectomy versus a tri-modality therapy, somehow in every aspect the tri-modality therapy was costly. So any comment on this and why it is maybe?
Radiation part. So chemotherapy is not costly. It's the cost of gemcitabine, or even we use cisplatin base. The cost is not much. So probably in our setting that it will cost around approximately around 60,000-70,000 to complete and total chemotherapy course. And radiotherapy,
in bladder therapy, we have to be very vigilant about the bladder volume and the target delegation.
Bladder radiotherapy has to be an IGRT,
IGRT,
undoubtedly, nothing less than that.
So the daily image guidance and the image guided radiotherapy, maybe that increases the cost of the total treatment.
Sir, from your side.
Basically, surgical component of it is no more expensive than doing it. QRPT is not a very expensive surgery compared to radical system.
Compared to radical, yes, yes.
So that way, probably the surgery does not add to the cost of the trimodal therapy. What adds probably the image guided therapy.
Yeah, I'll have to add on. So once the patient you have opted for bladder preservation, this follow-up has to be very stringent.
Yes.
So you have to add the cost of this follow-up there. So QRPT is not costly, chemotherapy is not costly, maybe radiation, okay, fine. But this regular cystoscopies, regular scans add to the cost.
Yeah, maybe that was the point.
Make the follow-up protocols.
Yeah.
So there is some fallacy of this data undoubtedly, like every data, because this is a multi-institutional retrospective series you're collecting. There's always some bias, but it is published in a big journal. So this is something in our scenario, like Abhay was saying, maybe it is true. The take-home message should be personalized, finally patient to patient, because it's a very difficult call to take. Even in their data, in Western data, the survival also is bit skewed. The cystectomy survive better, but again, it is a mix of everything. You have T2, you have T4, you have big tumor, you have existing hydronephrosis, CIS. So probably on a practical scenario, we'll never get an answer to this until it is really case by case, and it is just going to get complicated from here. I feel in bladder tumors. So I'm well within time. So let's take some final comments. So muscle invasive bladder cancer, RCIC versus TMC from each one of you. Points.
Trimodal therapy.
If patient is fit, I will give that neoadjuvant chemotherapy and followed by
Response assessment.
Medical. So if patient is fit, then of course that surgical modality I will do.
Sir.
To my mind, patients who are relatively advanced and they are not fit candidates for therapies. But if it is an if MRI is still localized to the bladder wall, preserve his bladder and can comply. I feel that it can comply with the regular follow-up. This would be, I will have it and probably offer a trimodal therapy in the early stage if I have detected.
I will agree. I will opt for the trimodal therapy if the selection criteria and meets the guidelines. Definitely a trimodal therapy, otherwise an RCIC.
So if RCIC, what technique?
In essence, this is not a treatment for advanced disease. It's a treatment where you can probably just cross the enter into the muscles and you have a nice surgery.
So if RCIC, what technique? The take-home message, robotics.
So that
Abhay is smiling, beaming with smile.
actually the randomized trials that has occurred with robotics and open.
I had a
has
slide
proved
of that. I skipped
no
it.
As far
advantage.
as open, sorry, I'll interrupt. As far as open versus lab versus
Versus
robot,
robot,
you
yes.
do not have any answer to
Yes.
it. The razor trial has clearly
There is
proved
a-
it.
Yes.
The oncological outcomes are equivalent. Let the surgeon and the patient choose. Robot obviously gives good results, then lab, and if you don't have anything, open.
So in fact, in razor trial, there was a point of more time-consuming surgeries by robot in the three arm.
This is the
when they-
early in the learning curve. Once
Yes,
the
so-
surgeon is through his learning curve, it would not change. The other problem, they raised the question of pneumoperitoneum-induced port-site
Yes,
metastasis,
yes,
but
yes.
that was only in that trial. We have never come across these things in any lab or a robotic surgery. So these are again new.
If you look at the general scenario, robotic surgery is a great level. You can even with there can maybe publications of very good result in open surgeries, but don't be under the misconception that open surgery are easy surgery. That is also dependent on the surgeon's experience, the setup, everything. So robotics rather gives a level playing field for surgeons of all calibers to do a perfect job.
So I was asking our Euro friend in Mumbai, in our center, so I will not name him, everybody will know. So he was telling, I will tell you a trick that in fact doing a good quality lab is more challenging than doing a robot. So his statement was, robot itna kuch nahi hai. If you have learned lab well, that is more difficult to do. Abhay, Abhay knows him very well.
Sir, yeah. So if you are a good lab surgeon, you don't require robot. That's no doubt about it, right?
That's what he was saying
Yeah,
on
yeah.
sir's presentation.
Second is, even I was not convinced myself that whether by doing a cystectomy by robotic, you are adding any benefit to the patient or not. But if you do and see the results, you are not going to find any oncological difference in the outcome.
No,
They are going to be
that's
the
not
same.
there in any of this.
But if you see this experience of the patient, the pain, the outcome, the recovery and everything is far, far, far better in robotics, and maybe if the patient can afford, you will definitely go for robotic. Coming to the surgeon's point of view, like me, I am very comfortable doing robotics. I mean, open surgeries. Even I can do a faster open cystectomy than robotics. And time is a kind of thing which is comes with experience. As your team is experienced, not about the surgeon. The surgical team, including assistant, NSS, everyone. The time is almost same at the end of your learning curve, both the techniques. And if you ask my experience, if I am the patient, I'll like to be operated by robot because
Because of the
efficiency
ease of-
advantage. Yes. And regarding the sport site recurrence and this peritoneal mets and everything, although there is no evidence, but in my experience, I have seen some recurrences. I have seen some peritoneal deposits after doing robotic cystectomies.
So, but there's definitely a learning curve
Yeah,
to it.
yeah.
So, do you have a standard of learning curve for that? I know from Intuitive they give some sort of learning curve certificate, right? Because in our center also we got Da Vinci recently, so I was hearing this.
Robotics has got a training protocol, training program, certification programs, and everything. And more or less, this training is now objective. So the things have changed over a period of time. Now the learning has become more objective based, and now we can assess whether at the end of the training the person, the surgery is capable of doing certain things or not. So now things are streamlined and objective and better now.
So similarly for radiation, if you want to do a bladder preservation, I feel this definitely needs a quality control in that. It's not just you can do this is not a run of the mill case. So the final coming from you related to radiation dose technique, especially the dose and technique.
The dose of the hypofractionated radiation, it's a continuous course radiation, concurrent with
So you'll do
chemotherapy.
55-20 with
55 grade 20 fraction, concurrent with chemotherapy.
and daily
only,
imaging.
bladder only with daily image guidance.
Now, Pradeep, from your the final cisplat remains the agent of choice.
Yes, that cisplatin, yes, cisplatin 5-FU can be used, but looking into that difficulty of using this regimen, so we have adopted to single agent gemcitabine base and doing well that most of the patients. So in my clinical practice, I give single agent gemcitabine concurrent with radiotherapy.
Manu, you wanted to.
Question to surgeons, how comfortable is this salvage cystectomies? I wanted your comments. Because
He had
that's
a
the
point,
main
but
question.
I skipped due to time.
Salvage is not comfortable, and the other way around I would present it. In a cases who have received neoadjuvant and then you take them for a cystectomy, your cystectomy does get difficult. But however, the RCTs that have showed, they say that it's not so. Similarly is the wound healing. So it gets difficult. There's no doubt about it. And again, here the robot plays a role, because the most difficult part becomes the posterior dissection, where you need to pick up the bladder and the prostate from the rectum. So there's very difficulty encountered while you try to do it as a salvage.
Some difference of opinion here. I don't find any difficulty in doing salvage cystectomies, but yeah, complication rates are more higher. Maybe the stricture rates is higher, and the leak is bit higher. Wound healing, that may not be that great difference. So, but surgery-wise, I don't find any difficulty in doing salvage cystectomies.
So, just the last comment. How, with all advances in imaging, patient plan for say a TURBT, then thinking of a bladder preservation, we have molecular subtyping coming. So, how in one liner, how a future bladder preservation protocol should look like?
It will have a different place for managing some nicely selected cases. It will definitely have a place. It has already got a place.
So, will you start using the molecular subtyping, say it is available, and select the cases for bladder
Those things will
preservation?
be in the clinical practice to categorize the aggressiveness of the tumor. Definitely it will be much more easier to choose cases.
Yeah, of course that bladder preservation, of course that till now that in our clinical practice that mostly for it is for urothelial. We avoid doing that where is that purely squamous or adeno or even other variant, the micropapillary variant. We avoid doing. Yes, of course that we like to do that molecular typing of the tumor. We have already shown that if patient is having any endocrine differentiation, all these cases we should avoid because of this high grade of the tumor. So in that case, yes, that for bladder preservation, of course, in one line that we have to choose the tumors properly for a better outcome of the disease. So proper that early stage, that tumors which is basically less aggressive, with the proper protocols that will improve the survival of.
Just quickly, last comment.
I would also like to add that with advances of techniques and proper typing, histological typing, and with molecular typing, it will definitely make the role of trimodal therapy much more prominent in future, because we can properly select cases, we can rule out the very aggressive variants, and variants like micropapillary or sarcomatoid or purely squamous, which are definitely very aggressive disease, might have a bit preferential treatment towards RCIC, but then other variants which are not so aggressive will definitely increase trimodal therapy.
Another thing, if there is molecular subtyping, if you consider in future some kind of immunotherapy,
Yes.
it can.
So, thank you.
Biggest role in a trimodal therapy is of the radiotherapist. You plan the treatment, you accurately deliver it.
Yes.
That is the crux. The other parts are more or less routine.
Thank you to all my panelists. I bring you guys Rain from Mumbai. It's an early morning. Thank you so much, Sayan, again, and thank you to all the panelists.
Thank you so much to our moderator, Dr. Tiranjan Basu sir, and all the esteemed panelists. So we'll proceed with the second panel, which is on management of high risk or metastatic prostate cancer. The moderator for the session will be Dr. M.V. Chandrakant sir. He is a senior consultant medical oncologist at Narayana Super Speciality Hospital, Howrah. The panelists for the session will be Dr. Swarnendu Mandal, Associate Professor, Department of Urology, AIIMS Bhubaneswar. Dr. Bhabesh Poladia, Senior Consultant Medical Oncologist. Dr. Suratika Majumdar, Consultant Medical Oncologist, Narayana Hospital, Kolkata. Dr. Manu Matthew, Assistant Professor, Radiation Oncology, CMC Vellore. Dr. Vikram Lele, Director, Department of Nuclear Medicine and PET-CT, Jaslok Hospital, Mumbai. And Dr. Siddharth Kumar, Consultant Urologist, Medica Hospital, Ranchi. Thank you.
So, good morning, everyone. I think we had an excellent moderation by Dr. Tiranjan in the last panel. So, just in continuity with that, I will be presenting on high risk or metastatic prostate cancer. So these are my panelists. I think instead of Dr. Gaurav, we have Dr. Swarnendu join. It was a last minute modification. And then we have Dr. Siddharth Kumar. And then we have two medical oncologists, Dr. Bhavesh, Dr. Suratika. And we have one radiation oncologist. And we have one nuclear medicine, Dr. Vikram Lele. Okay. So these were my first reactions yesterday, because yesterday was when I came to know that I am supposed to moderate, and so I was shocked and probably have recovered. So I will discuss my case with these four clinical scenarios. First case would be biochemical relapse. The second case scenario would be locally advanced prostate cancer. Third one would be metastatic hormone sensitive prostate cancer, and the fourth will be the radioactive therapies and so on. So the challenge is we have multi-modalities and we have to involve all of them, and that is how these cases are basically made. Okay, so I will start with the first case. So if there's Dr. Gaurav, and I would request Dr. Swarnendu to please take up, and I'm sorry for the last minute modification. So here is a 60-year-old gentleman. Is an unfavorable intermediate risk prostate cancer. Let us not waste in classifying the risk. So it's the Gleason's 8, and it's a T2B with a PSA of 15. Okay. So I will start with Dr. Swarnendu and then Dr. Siddharth. So what would you do? Are you comfortable operating this, Dr. Swarnendu? We can start.
I'll need further tests if possible, a PSMA PET-CT if you do not have it, a bone scan and a normal
CT abdomen.
Okay.
For
So
the
if
rest-
okay, so non-metastatic,
non-metastatic.
no nodes.
I am a surgeon, I'll be biased towards RP. I'll be biased towards RP.
RP.
Yeah.
Okay. So how do you counsel your patient? You know, like why surgery? Why not radiation? You know, non-invasive modalities. What are the positive things you will think of?
Again, as I said in the last session, this would be a single shot for the next 5 years. I think I would give him a negative margin and a PSA which is acceptable.
Okay. Okay. So Dr. Siddharth, same thoughts.
Same thoughts. I would also agree if I can achieve the trifecta, thinking with the imaging, pre-operative imaging, no metastasis, I would also be a bit biased towards surgery.
Okay. Surgeon wants to operate. Manu, you want to operate? Send for surgery, or you want to?
Yeah, I think this is an ideal case to be discussed in the multidisciplinary tumor board because it's in the borderline between not a high risk proper, but it's not a very low risk also. So I think we should have a combined discussion about both options here for the patient, either a surgery in the form of radical prostatectomy or an EBRT. So I think a patient discussion is very important in this before making a decision.
Fair enough. So there are multiple modalities, and MDT would answer. And again, patient shared decision is important. So these are some pros and cons of each. I think we already dealt with this. So each modality has its own pros and cons, but there are some situations like intractable non-cancellated lower urinary tract symptoms where RP would be preferred over RT. And if there is a tumor fixation to adjacent structures, here probably you will prefer RT and not RP. Okay. So this patient went on to receive radiation, and then the PSA reduced to 0.2. So Dr. Manu, what about radiation ADT? Would you give ADT in these patients with the intermediate risk unfavorable?
If we have decided that the patient is going ahead with the RT and the plan, definitely a short course ADT will be recommended because it's unfavorable intermediate risk.
Okay. How long would you give? Like
6 months at least, because if it's we consider it's intermediate.
Okay. So this patient, as Dr. Manu planned, this patient went on for ADT for 6 months, and then this patient was observed, and 10 months after stopping ADT, the PSA serially went up from 0.2 to 1.5 to 4 to 10. So there is definite doubling of PSA, and it is around within 10 months. Okay. So now I will go to Dr. Vikram. So Dr. Vikram, you want to pick up metastasis, right? So what would you advise? You know, or would you have one modality over another? So how do you advise us?
Well, currently now PSMA PET scan is the best modality because of its very high sensitivity and a relatively high specificity. And it is sensitive at all ranges of PSA, right from less than 0.2 to any level. The sensitivity ranges to almost 98 to 99% at a PSA level of 2 and above. And it's around 60% at a level of 0.2. So that would be, without doubt, the best modality we have at the moment.
Okay. So supposing your PSA is 30, 35. So there, if you compare and contrast a PSMA versus a CT, you know, I think does PSMA really pick up more when the PSA is high?
Compared to?
PSA less than 10.
Well, the higher the PSA value, it's a more burden of disease is higher, and we are likely to pick up more lesions.
Okay, so no, the thing is that if the burden of disease is high, probably CT scan will come close to a PSMA PET. When the burden of disease is low, probably PSMA is picking up more disease.
Well, there has been enough comparisons now with CT, MRI and PSMA PET, and there is no doubt as far as the lymph nodal and the skeletal lesions are concerned, the PSMA PET is far superior. And as you know, the PSMA PET is a PSMA PET CT. It includes the full diagnostic CT along with the PET. So it's now, we do not say CT anymore, it's combined CT along with it.
Okay. So This patient did undergo a PSMA PET CT and there was no uptake, and it's a pure biochemical recurrence, and the definition of biochemical recurrence is above 0.2 for RP and above 2 for RT. Okay, so now coming on to surgeons again, Dr. Shwanendu. So have you ever done a salvage surgery in a patient, or would you do a biopsy? So how do you deal with this biochemical recurrence alone post radical RT?
I would like to give him, looking at the PSA, see the concept of radiotherapy and RP are equivalent. It's not a patient who is not fit for RP goes to RT. A patient who is fit for RP can go to RT as well. So if he has got RT and post RT at 6 months he has this recurrence, I believe he has a systemic disease. So I would still be thinking of treating him with other systemic therapy upfront rather than going a salvage prostatectomy now.
So which patient do you consider salvage prostatectomy, or is it an obsolete term?
After I've exhausted my other systemic therapies and still the PAC is not under control.
Okay. So Dr. Siddharth,
I agree with sir. Like both the concept of ADT-RT as well as RARP is a control of the localized disease. Considering the rising PSA level despite a curative intent being given, I would consider it to be a systemic disease, and yes, salvage surgery would be difficult in those situations.
It's early recurrence, after 6 months the disease starts rising, so I feel it's more like a local failure rather than a systemic disease. So I will maybe do the MRI to see the local disease.
have you ever come across the situations of doing a biopsy and then there is a viable disease and then you do a salvage post-RT? Have you ever come across these situations?
Not informative, then we require perhaps for offering the radical surgery.
Okay.
So, I make a point, sir. It is extremely unusual for a PSMA PET to be negative with a PSA of more than 10. So I would probably also do an FDG PET in this situation, because you're probably dealing with an undifferentiated disease, and that will be picked up by.
So there is, even in the PSMA era, I understood. So even in the PSMA era, there is something called biochemical recurrence, you know. So probably it is the time that we are picking up the PSA has risen, and there is a time lag between the PSA rise and the actual. So there is a concept of biochemical recurrence in the present day, and there's a different disease, and there is different guidelines.
Do these variants, like the ones that we are talking about, are they that PSA expressive? Like, will they be that having that high PSA and not coming up on a PSMA PET CT, which will show up in a FDG PET?
Most of these undifferentiated ones will lose their PSMA expression, and the literature says that about 10% of prostate cancers will not show PSMA expression, only 10%. 90% will show PSMA expression, and as they become more undifferentiated, the PSMA expression goes down. But this biochemical recurrence, the amount of sensitivity which we have now with the new generation machines and the new ligands, we are picking up disease at 0.03 PSA. So I am very surprised that at 10 PSA we are getting a negative scan. I would review that scan. We do delayed imaging. If we have a negative image at 1 hour,
Okay.
we do a delayed imaging at 3 hours, and we invariably pick up.
Okay. So let's say, Manu, we have done a biopsy, and there is viable disease in the prostate. So would you give re-RT in that place?
Not in this situation, because already patient has received a high dose of, it's like a radical RT has been already over, and within 6 months brachytherapy, I don't think it's a feasible option. And this time period is too short.
Okay. Okay. So what about these patients, you know, so Shwanendu already was saying about systemic therapy, you know, so what systemic therapy would you give in these situations? I mean, this patient has already stopped ADT 6 months before.
The standard step ladder pattern, I will start with abiraterone and see how he responds to it.
So this patient is hormone sensitive, non-metastatic.
Yeah, we have data on high volume disease. The latitude trial tells
No, this
you.
is non-metastatic, no?
Yeah, so even for M0 disease, you can start abiraterone, and that was the subset analysis coming from the latitude trial.
That we have a next case. Like this is
Yeah.
something like a biochemical recurrence that has failed post.
So you have already given him goserelin,
Yeah.
so you are done with it. You can only measure to see the testosterone levels are less than 20. I would be
So this
skeptical.
patient had stopped goserelin 6 months back, and now still it continues to be hormone-sensitive disease.
Yeah, so we need to continue ADT, either form of the goserelin or a degarelix, and then I think you can add abiraterone.
You feel like you can add
Yeah,
systemic
yeah.
therapy. Okay. So there is something like deferred ADT, even in this situation. So what about this?
Just the early one. We will continue with the.
Okay.
Not for this patient. Not for this patient.
What about Dr. Manu? You want to comment on intermittent versus continuous ADT in this situation? Any point of time have you come across these issues?
Not, I have heard only intermittent in metastatic setting, right? Do we discuss in the, I am not aware about that.
Okay. So the question of intermittent comes to have a good palliative drug, because ADT is an issue with a patient like this is non-metastatic, only biochemical recurrence. So intermittent sort of probably can be tried in those patients where the rapidity is not much. So what if your intent is overall survival as the endpoint, then probably continuous. But if quality of life is an endpoint, then you can use intermittent. Okay. So for systemic therapies, there were multiple trials, and apalutamide was there, and it was a negative trial. So, any you want to give a systemic therapy at this point of time?
So I think the CAB, the complete androgen blockade, is something which will probably give the response.
Okay. So this patient went on to take ADT alone. That's fine. So now coming on to the second case, this was.
Yeah. So 60 years male, localized disease, idiopathitis, hormone therapy given, RT given, and then he has got recurrence, PSA is rising, no metastatic disease. Why not offering RP?
That's what I asked.
High rise of PSA. The dictum that goes is after a RP or a RT, if you have a PSA which is around 2, you think of a local recurrence. But if you have a PSA of around 10, you are probably not looking at a local recurrence. You are looking at a systemic recurrence. So that is one. The other thing I would do is a second biopsy just for getting those HHR and all those genetic analysis done, so that I would know why exactly he is not responding to these things. So that is what.
So just saying the guidelines, the practice changes. So the guidelines say that you must do a biopsy of the prostate. If there is viable disease, you can go ahead with RP if possible. And the role of systemic therapy options, whatever PARP, whatever you say, they are all negative. Probably you can give ADT alone. So that's what the biochemical recurrence guidelines say. But I agree, it's case to case and time to PSA doubling, all this happen. Fine. So let's not waste and let's come to the next case. What Dr. Swanendu was saying. So this is 65-year-old male, high risk, locally advanced. Okay, stage 4A. So nodal disease is stage 4A. And Gleason's 8 adeno-CA prostate and quite locally advanced. Okay, so again I will start with surgeons. So
Yes, difficult scenario. We don't have guidelines on this, but yes, if I have a robot, I'll go for RP. If I do not have a robot like me, I have lab, I'll go with a neoadjuvant. Yes, this is not there in the guidelines. I will go with neoadjuvant ADT plus abiraterone. There are good quality RCTs telling that work. 3 cycles of ADT and neoadjuvant abiraterone followed by an RP.
Siddharth, any thoughts?
In this particular case, I'll be tilted more towards ADT with RT because I also don't have a robot, and I think patient might get much more benefit of the second curative arm.
Okay. But Abhay, would you operate?
This is not a case to be operated initially. So maybe I will send to my radiation for radiation therapy.
Okay. So, Manu, so what would you do?
Yeah, I think this kind of patients we should directly consider ABRT and ADT because definitely there will be multimodal treatment. Otherwise, there is no option of only one single option.
Understood. So radiation is the way to go. And this is radical prostatectomy in node positive disease, group 4-5, minimal suspected regional lymph node spread, and there is lymph node positive only in PET and not in normal way. And if it is less than 2 centimeters, these are the places where you can still go ahead and operate these patients. And you can subject these for post-operative radiation after you have done. And ADT becomes important, and NHD, as he was mentioning, is the way to go. So this subset, still you guys can operate. And this is the NCCN evidence of local therapy even in a locally advanced disease, 3,000 node positive patients, 2,000 received RT versus RP. So here, local therapy does improve survival. RT equals RP in long-term outcomes. And there is a retrospective study from SEAL database. Here what they are saying is if I do first RP and then RT, they have a lower risk of mortality than giving RT plus ADT. However, there is a higher risk of erectile dysfunction. So there is a comparison of RP plus RT better than RT alone. So you may still operate select subgroup patients if it is T34N0 or T34N1. Okay, so Dr. Manu, so how long would you give ADT for these patients, and how do you give? Before, after, during, how do you give?
Yeah, this patient is a high risk, or even very high risk, we can say, because of the node positive. Definitely patient should go for neoadjuvant ADT, at least 3 months, and then we'll reassess the response of the primary as well as the nodes. Then we can go out with the radical RT, then followed by ADT will continue up to at least 2 years, 2 to 3 years.
Excellent. So you will give before, during, and after, and up to 2 years. Excellent. So this is some data that says that RT plus ADT is better than RT alone, and for 2 years, as he very correctly said, 2 months before, during, and 2 years after is the way to go. And these are some data for sequencing, So this is the Sandstorm study. What does it say? It says that this was recently published in February 2023. It says that neoadjuvant or concurrent is better than concurrent adjuvant. Like if you're doing whole pelvis RT, it's fine. If you're doing prostate only RT, then it matters. So, but ADT is the way to go before, during, and after. Okay. So now I will come to Dr. Swaratika. Dr. Swaratika, this is a high risk locally advanced prostate cancer. I just go back to the case.
Yes.
This is the patient you have. The patient has completed radiation, and you know the Stampede data. So would you give abiraterone for this patient?
Yes, I would give it for 2 years.
Okay. So first of all, would radiation oncology refer to medical oncology for this? Do you believe
should be a tumor board discussion anyway?
Yeah.
Yeah, I think this every time we have a discussion, because many times patients comes to with the starting abiraterone also with ADT, and then we consider RT. It's not always
So you were just saying in the discussion that you gave abiraterone even in the neoadjuvant setting, right?
Yeah. I think in Stampede they did not at the time of randomization they did not time it with reference to RT. It was based on ADT versus ADT plus abiraterone, and then RT was included as a part of that disease, especially if they had a good response. So I would definitely, if the patient is being started on ADT, there's no harm done in starting abiraterone.
Correct. So who benefits from abiraterone? Any node positive or node negative with any of the two, T3-4, grade group 4-5 or PSA more than 40. So these would benefit with abiraterone, and this is the Stampede data. So this is a pooled analysis of 2,000 patients. 85% received local RT, and ADT plus abiraterone versus ADT. There is a 6-year mortality-free survival. Metastatic-free survival. I think it's mortality-free survival. 82 versus 69%. Hazard ratio is 0.5. And then for overall survival, the hazard ratio is 0.6. And there is no benefit of combining ENZA with abiraterone. So surgeons, are you convinced about, and radiation oncologists are convinced about the data of giving systemic therapy in this setting? Any comments?
I would still not think of Stampede. These are different era studies. The latest you have is the Peace 1 trial, which compares the standard of care, that is docetaxel with ADT. Then you keep adding it.
This is a non-metastatic.
I understand, but you can always extrapolate that data to these data. So finally they would end up.
So you would want to give chemo also. Yeah, we are very happy to give if you can.
I would say the first hit has to be the worst hit. so that patient gets the benefit. So I still feel you have to realize these data not just with a bit of pinch of salt, it's a lot of pinch of salt. The guidelines, the recruitment of these patients are completely different with the ones which we have now. These data are compared with a bone scan, we have a PSMA PET CT, the drugs that we have, the genetic analysis.
So up to now we are giving only abiraterone in this particular setting, and adding extra has not greatly benefited. Okay.
I feel that definitely ADT can be added with abiraterone to give that extra advantage.
True. So abiraterone is the one that has shown some benefit. Okay, quickly going for metastatic hormone-sensitive prostate cancer setting. He just let us one into us. Talking, 68-year-old fit metastatic HSPC, extensive bone mets, ribs, humerus, PSA more than 100. So, Dr. Bhavesh, what would you do for this patient?
So, obviously, we'll start with the complete androgen blockade. We'll give the option of surgery versus medical castration, and then we'll observe the patient, see the PSA, and then accordingly we'll do the treatment.
This patient is a high risk with a heavy disease burden, a lot of high volume disease. So this is a definition.
With this character, I would like to even add docetaxel post bilateral oncectomy, so that we can give the best maximum benefit and maximum survival advantage to the patient.
True. So, Dr. Pralatika, any thoughts?
No, sir. Triple therapy, androgen blockade, docetaxel, followed by abiraterone based on PIS1. But I would also, in addition, get a germline testing done because that's the standard recommendation for all prostate now. It may not benefit him, but I think it might benefit his children.
Okay, so you feel the triplet is standard of care in the present day in this patient?
Sorry, sir?
Is triplet the standard of care?
Yes, so based on, I think the most impactful thing for a metastatic prostate cancer is to maintain that period of hormone sensitiveness. Because even a localized CRPC is much more difficult to contain than a hormone sensitive metastatic disease. So whatever increases your PFS will be worthwhile in prostate, because OS may not change, but the PFS will determine how well the patient lives. Docetaxel acutely might affect quality of life, but it's just a 6-month thing. It's easy to get over.
Understood.
50 mg weekly.
So you have ADT plus docetaxel is there for a heavy disease burden.
Yes.
And which one do you use? You use darolutamide or you use abiraterone?
So abiraterone. It's just my.
Why so?
Because accessibility, experience, darolutamide is
cost no issues.
Cost no issues. Even then, I'm quite comfortable with abiraterone. Darolutamide has not shown such a benefit as compared to abiraterone. It was compared with placebo alone. So I'm okay with abiraterone.
Okay, so let's quickly revise the ARASENS trial. It is metastatic hormone-sensitive prostate cancer, heavy disease burden, ADT plus DOSI plus DARO versus ADT plus DOSI, 1,300 patients. 80% had bone, 20% had visceral mets, 85% had synchronous mets. Remember, they did have metachronous mets also. The 4-year overall survival is significantly different. The hazard ratio is 0.68. So therefore, triplet is better than doublet. And remember, the ADT plus docetaxel arm at progression received multiple lines of therapy, including abiraterone, PARP inhibitors, and so on. So this did reflect the real world scenario. And the PIS1 include only synchronous disease. It did not include metachronous disease. Head-to-head comparison of abiraterone versus no abiraterone. Median overall survival not reduced as 4.4 years. Hazard ratio is 0.75. Toxicity is not worse. Remember, majority of them received radiation even in this heavy disease burden in this particular trial. So what are the issues with triplet data? The comparison is ADT plus DOSI plus DARO. It is not compared with ADT plus darolutamide. You don't know whether docetaxel added any advantage, number one. Number two, again, with abiraterone, we don't know. We have evidence for ADT plus abiraterone. We don't know how much docetaxel is adding. So this comparison is a little unfair, number one. Number two, the other things are 15% were metachronous in ARASENS. We don't have data for metachronous in a big way, and only synchronous in PIS1. And number two, disease burden is not addressed in ARASENS. They have given docetaxel plus darolutamide for irrespective disease burden. That is one more. And majority would like to give only tablets in the MHSPC setting. Why you want to trouble this patient early on in the disease? And therefore there is a bit of in the mind that no docetaxel now, let me give abiraterone and keep later. And node-only disease is not addressed anywhere in. So if you have multiple nodes, that is not addressed in this trials. Okay, so now we will come to topic.
Do we not consider send to for orchidectomy these patients, or you still proceed with medical ADT?
ADT plus ADT will go.
Don't cut, but it will be lifelong, right? ADT for these patients.
So the moment the patient has metastatic prostate cancer, he has no right to have his testis.
That means
Okay, so whatever the way it is.
As a matter of fact, there's a new concept that is coming up that probably your injections does better than a orchiectomy. The hypothesis, which has not been proved, is by removing testicles, you are removing his gonadal testosterone. You are not
So if
preventing
you're
the
attending
conversion
the-
of those testosterone to estrogen from the adrenals. So that probably, again, this is an hypothesis, not
So if
proven.
you're attending a Digarelix symposium, probably they will give you the slides of comparing orchidectomy versus Digarelix, and Digarelix is more cardiac safe.
No, then
Yeah,
not just composition. The other thing is what I suggest in the first slide. The reason why Gosarelin was chosen upfront over a lubrolide is again a debate sort of thing.
So I will tell you why orchidectomy has been sort of said. So if you remove testes, the FSH levels go up, right? So the FSH levels will cause some lipid deposit and all those things. If you give DNRH antagonist, then there is no FSH at all, and it is cardiac safe. That is the reason why people are promoting it, but there is no head-to-head comparison. Okay. So radium 223, I think I will come to Dr. Vikram right now. So alpha, it's an alpha 1 shorter distance marrow spared bone seeking. There's a randomized trial improving overall survival in CRPC. Combined with abiraterone, there are more fractures you can use with bone modifying agents. So these are the hard questions stored for you, Dr. Vikram. So when do you use these radioactive therapies?
Okay, as far as the radium 223 is concerned, it is out because we don't have it in India. It is not sold, and it will never come to India. So and only affects only the bone metastasis. So we will not discuss it anymore. In India, of course, we have the lutetium and actinium PSMA, and that is available everywhere. And not only does it take care of the bone metastasis, it also takes care of the lymph node and the visceral metastasis. So that would be the radioisotope of choice. And when to use? Currently, according to the VISION trial, it is to be used when you have failed with the taxane therapy. Only then, and it is progressed after that, we come into the picture. But there are now a lot of trials going on where we are coming in earlier. There are 2 trials which have shown that taxane naive people do better if given lutetium PSMA as compared to those who have already taken taxane.
Okay.
So whoever has PSMA highly positive with a SUV more than 10, who has multiple PSMA avid lesions, is a suitable candidate for lutetium PSMA therapy. And right now it is only those who have failed taxanes, but in future it will be
Understood. So would you give in bone only, asymptomatic bone mets too?
Asymptomatic, currently we are giving when there is some pain, but if the disease burden is very high, multiple bones are involved, even if he is asymptomatic, we should give.
Okay, so we have radium is out, lutetium or actinium?
Lutetium is the one which is available everywhere. Actinium is 200 times more powerful than lutetium. It's an alpha emitter. It has a very short range. It is safer when extensive bone metastases are there. It will prevent bone marrow suppression. But it is extremely expensive. One dose costs about 5.5 lakh rupees. While lutetium, one dose costs around 1.45 lakh rupees. The imported one will be 2.6. So there is no availability of actinium. So at the moment, lutetium is the bread and butter.
So would you recommend combine when the treatment is going on? Would you ask them to continue on these oral tablets or anything like that?
Yes. Now, if the patient is on enzalutamide, it increases the expression of the PSMA receptors. So there's a combination of enzalutamide and lutetium will be synergistic.
Oh,
much better.
I think we had an excellent panel discussion, and this is for the breakfast. So, but this is not there in Bengal. This is in Bangalore. This is one of the big. So, just to remind that all our patients go to South and come back to us. Thank you. Thanks so much. Yeah. I thank all of my panelists for their active participation.
I'll request the panelists and the moderator to kindly be on stage. I invite Dr. P.K. Mishra sir to kindly felicitate all the dignitaries in this particular session. Firstly, Dr. M.V. Chandrakant sir, the moderator for the panel. A big round of applause please from everyone present in the hall. Dr. Bhabesh Poladia sir. Dr. Swaratika Majumdar. Dr. Manu Matthew. Dr. Vikram Lele. Dr. Siddharth Kumar.
Good morning, sir. Good morning, good morning. My apologies.
Can we kindly have a photo for the panel members of this particular panel, please? Dr. Swanenu Mandi, sorry.
Thank you, Chandrakant, for helping me. Because I can see you. Thank you for helping. Your call. Whenever you tell me, I am ready, so whenever you want.
We kindly invite the moderator and the panelists for this session for a photograph, please.
Starting very shortly. It will take just 1 minute, sir. Whenever you tell. Swaratika is also here. Hi, Swaratika. Good morning. Good to see you.
I request Dr. P.K. Mishra sir to kindly be on stage and felicitate the other members. I would now call up the panel 1 members. Moderator for the session, Dr. Thiranjan Basu sir. Dr. Arijit Sen. Dr. Pradeep Mandal. I also invite Dr. Siddharth Kumar sir on stage for the collective photograph, please. I request Dr. Abhay Kumar sir to kindly felicitate our chairperson for the entire session, Dr. P.K. Mishra sir, please.
big round of applause, please, everyone present in the crowd. I'll hand over the mic to Abhay Kumar sir.
I think the next speaker is online and waiting, so I will not take a long time. But I'd like to thank everyone who came on this morning and supported. And we had a very good academic meeting, and I was really surprised. I mean, seeing the enthusiasm, seeing the energy in the morning. Thank you all.
Good morning, everyone. Welcome you all. Our next session will be on oral cavity cancers. So we have our teacher, our mentor, none other than Dr. Kumar Prabhat sir. He needs no introduction in India, wherever you go, and abroad also. He's our mentor. He's the senior medical oncology faculty, as well as the head of the department of medical oncology at Tata Memorial Hospital, Mumbai. So Kumar sir will be delivering a talk on the role of neoadjuvant therapy in oral cancers, oral cavity cancers, and when and how. So before Kumar sir starts speaking, sir was ready to visit here. Sir was supposed to come here, but some unfortunate family-related issues happened. So, but sir is kind enough to deliver his lecture. He is ready to on Zoom link. So, may I first call upon the dais the chairpersons for this session.
Yes, our chairperson for this session are Dr. Doipayan Mukherjee sir. Sir is a senior ENT surgeon at KPC Medical College, and he is the president of the AI West Bengal. Very active, and hopefully soon he is going to become the president of the AI national body. So please on the stage. And to accompany him is our very senior onco-reconstructive surgeon, Dr. Anupam Golar sir. So please be on the stage. Sir is one of the senior most plastic reconstructive surgeons of the city, attached to CMRI hospitals, and he needs no introduction. So with our esteemed chairpersons on the dais, we'll request Dr. Prabhat sir to please start his talk. Thank you, sir. Over to you.
Thank you, Steve, and thank you. So good to see both of you. Sure, very near future we'll see you both of you in person. So starting my presentation, can I start, Siddhi?
Yes, sir. Sure, sir.
I'll share my slides. Can you see my slides?
Yes, sir. We can see.
So the topic given to me is neoadjuvant chemotherapy in oral cavity cancer, and primarily the data comes from TMH. So it's good to present this because always close to my heart, and we, I have been associated with this from the beginning, and I'll be focusing on that part. So there are many aspects, but the area where it will be very relevant for many people going in the clinic tomorrow. Starting with that, why we need some more treatment than what we have, and what we have is surgery followed by radiotherapy or chemoradiation. What do we know? That in spite of all the effort done, almost more than half of the patients they relapse, and if the surgery is done in in oral cavity cancer, there is a disfigurement, and you do have many facial changes, which is troubling for patients, and that's the reason we look for. Can we have another modality which may improve the outcome and also improve the quality of life of the patient? Now, another issue comes, what can be resected and what can't be? So in oral cavity cancer, you do have a fair amount of interplay between the improving the life of the patient and also what kind of morbidity we give. I'm showing you an example, and there are many of them. This is one of the examples, that the total gastrectomy, not necessarily everyone wants to operate, suggesting that it doesn't mean it's not resectable, but because of morbidity, not many clinicians think it is worth doing it, highlighting the interplay between the morbidity and improving life. Showing you some of the kind of patients we see in the clinic, which becomes tough to suggest that what will happen if we operate them initially, or is it possible to operate them? Again, some of the example what I showed you. I'm sure lots of these are the patients which we see in the clinic, and many in the audience would have been seeing in the clinic. Now, how do we decide that what is borderline resectable? Because these are the patients where the question arises that are they resectable or not, and this was one of our first effort where we tried to define which are the tumor which are borderline resectable, means where you can't get the margin, but we think that later on maybe if you try something we can resect them. So these are the 4 situations. There are more than 4, but 4 commonly which we try to talk about it and which we defined in the paper, that if you have a tumor up to zygoma, if you have a tumor close to high tumor involving vallicula and high ITF involvement, that is above sigmoid notch, these are the patients who are technically unresectable because you may not get more than a centimeter margin if you resect them, and that's the reason something more needs to be done. So these were our initial paper, and what it suggested that yes, if we approach these patients with chemotherapy and subsequently go for resection, almost 40% of all patients can undergo surgery. And subsequently it also suggested in the same paper that the median survival improves for the patient who underwent surgery after neoadjuvant chemotherapy as compared to who didn't. Now, is there a similar impact in T4B tumor? And this was another paper by us, which was exclusively for T4B tumor, and again borderline resectable, or we call it technically unresectable. We use it interchangeably. And again we found that yes, you do have 1/3 of the patient who can undergo surgery after giving chemotherapy in this setting. If we have not done it, these are the patients who would have had a median survival of around 8 months or 6 months if this approach was not used, because if they were technically unresectable, they were the patient who would have gone for radiotherapy or palliative chemotherapy. Now we also try to define that if the NSCT in technically unresectable, what are the indications, what are the drugs, what is the benefit, the adjuvant treatment, and the margin positivity. Because this was a relatively new concept in oral cavity cancer, we do know this concept is fairly commonly used in pancreatic cancer. This was subsequent data because this is a larger one, 721 patients. So this allowed to do many subgroup analysis, and which also defined many of those questions which I put in earlier. So first we defined, this was our previous paper, that which are the patients which is unresectable. These are some of the criteria. This was the method we used in the clinic. This was patients who were going through these routine treatment in this format, which was pre-decided by the clinicians in the clinic that how we are going to treat these patients. And these were the statistics and the data analysis which was used, showing the baseline characteristics. This was the routine overall average demographic feature for oral cavity cancer in our population. We did have some PS performance status 2 patients also, and we also did have fair number of tongue cancer patients also. Now, what were the number of patients in which different indications where we had this neoadjuvant chemotherapy being tried? Primarily for tumor up to zygoma, and followed by vallicula involvement, ITF involvement, and extensive skin infiltration. Chemotherapy used, there were all kinds of chemotherapy which was used, and that also was one of the problem, but also gave opportunity that we can analyze those different chemotherapy regimen in our clinic. 84% of the patients completed at least 2 cycles of chemotherapy, suggesting that it is possible to deliver it. Post-chemotherapy, 43% of the patients underwent surgery, suggesting that if we started with 100 odd patients, almost 43 patients undergo surgery if we use this approach, and otherwise these are the patients who would have gone for palliative systemic therapy or radiotherapy or chemoradiation in this setting. This also data suggests that if they undergo surgery, they do better as compared to if they don't. And what it suggests, that at 2 years, almost 50% patients they survive long term, suggesting if you start from 100, 25% of the patients they become relatively long term survivor. We had update data which is not there in this presentation, which we presented some time back, and suggest that the people, if they survive beyond 2 years, they become long term survivors. What happens if we give adjuvant or if we don't give adjuvant? Because a whole lot of people at Tata Hospital, they take treatment outside, and when we send them outside, whole lot of people, they don't end up taking adjuvant treatment, and that allowed us to compare the patient who received adjuvant therapy and who didn't. And it suggests that giving adjuvant therapy is important, and our center, we do end up giving chemoradiation in the setting. Now, factor impacting survival, and what we can see here, the most important is what kind of local treatment we give. So most important is you can give local treatment as surgery. These are the patients who will benefit, and converting these technically unresectable patients with neoadjuvant chemotherapy may add life to these patients. What are more issues with this approach? What happens to complications? What happens to margins? What happens to CTRT after surgery? What happens to local failure if we do this revised margin approach in these patients? Elderly patients, 2 versus 3 drug, and DPYD, do we need to do it? Starting with the margin, this was a retrospective analysis of and doing a match pair analysis for T4 tumor who underwent surgery upfront, and what it suggests that the positive margin and closed margins were similar between these two approaches, suggesting that if we use a revised margin after neoadjuvant chemotherapy, that does not increase the margin positivity. Is there an increase in complications? And again, this was a match pair analysis, and it does suggest that if we give neoadjuvant chemotherapy, post-operative complication doesn't increase. What happens with CTRT after chemotherapy? It does lead to some toxicity, not something unusually very toxic, but if you use cisplatin, there is a trend towards increase in serum creatine in these patients, and for which we should be a bit careful about when we deliver cisplatin after cisplatin-based neoadjuvant chemotherapy in these patients. What happens to compliance? And this is usually an issue for neoadjuvant chemotherapy in Indian context, and this was our paper which suggested that our compliance is good, but yes, 40% patients, they are not compliant, and we didn't find a factor which predicts it, but this gives a food for thought that we need to intervene and do further work to decrease this non-compliance rate in our patients. Elderly patient, can we give this treatment? Can we use this approach? In selected patients, this data suggests that yes, you can use this approach with a similar outcome, but I need to concede that it is not true for every elderly patient. This is true for those selected elderly patients who are fit and where we use this approach. Now, do we use the different kind of drugs and in which sites it has been used? And what you can see that all kind of chemotherapy combinations has been used in different sites. And the toxicity wise, it appears that you do, this toxicity does increase, but not necessarily when we use this double combination chemotherapy that is very toxic. Now again, coming back to compliance with our data in some other setting, not only an oral cavity setting, it does appear that neoadjuvant chemotherapy compliance is good. CTRT, if we use in organ preservation, this is not for oral cavity cancer. There was some oral cavity cancer in that data set, suggesting that people do take CTRT well if we choose those patients carefully in this setting. And this was primarily hypopharyngeal and laryngeal cancer data, suggesting that in those patients where the resection is the issue, one can use neoadjuvant chemotherapy and go for resection subsequently, but that's not the topic for today's discussion. Does the 3 drug is better than 2 drug? And this was a retrospective analysis which suggested that that is the case, and this was substantiated by our randomized trial which we presented in the ASCO last year, which is in the process for publication. Do we need to do molecular marker for deciding treatment? DPYD rate, this was our first paper suggesting that DPYD rate, at least in head and neck cancer in our population, is higher, and that is important. And this suggested that if you do have DPYD mutation, then those patients have far more complications, that is almost doubling of the complication as compared to if you don't have it, suggesting it is important to do it. If it is heterozygous, you may have to modify the dose. If it is homozygous, then maybe you may have to remove the giving 5FU. Now, does the HPV make a difference? This was initial paper, has not been substantiated, suggesting that HPV positivity rate is pretty far and few in oral cavity cancer, and maybe there is some trend towards patient responding better. What it did after these all work, it suggests that this is part of our NCG guideline, this is part of our ICMR guideline, and it is fairly commonly used. And the survey done by one of a clinician in Bangalore suggested that 2/3 of the clinicians, they use this approach in their clinic if they get these kind of patients in the clinic, suggesting that these approach what we develop based on all the patients from Tata Hospital, there is a fair uptake in the clinic. In conclusion, neoadjuvant chemotherapy makes 43% of patients resectable in technically unresectable patient. Patient undergoing surgery has a better outcome. Revised margin does not increase the R positive resection, and neoadjuvant chemotherapy does not increase surgical complication. It can be given in elderly patients. DPYD testing is important. HPV needs to be explored further. These are my acknowledgements for my colleagues from my own department and the head and neck DMG. Thank you. We'll be happy to take any questions if we have. I didn't cover the resectable part because we thought in 15 minutes I can cover only one segment, or unresectable part, but we'll be happy to take questions if there's any.
Right, so thank you so much for your talk, sir. I think we are running a bit slow on time, so we'll keep the questions for later, and we do have a panel discussion just coming up, so I think questions can be managed.
Thank you.
So thank you once again for joining us virtually. Thank you so much, sir.
Thank you so much, sir. We shall now proceed on to the next talk. The next talk is on management of neck and oral cancers, and this shall be presented by Dr. Kapila Manikanthan, Consultant Department of Head and Neck Surgery, Tata Medical Center, Kolkata.
Good morning. Good morning. It's already good afternoon. I am Dr. Kapila Manikanthan, Senior Consultant in Head and Neck Surgery at Tata Medical Center. Today they've given me the topic of management of the neck and oral cancer. So this one slide should probably tell us why this is such an important topic. Because with each increase in the number of nodes, the survival drops. So management of the neck is very important. Nodal metastasis decreases the survival to 50%, and it is usually a predictable pattern of spread. How the pattern of spread occurs, we will get to in more detail. But despite all that, the management of it has some amount of functional morbidity, and we need to balance the oncological outcomes with our functional outcomes. And we'll go more into detail as we go through this. The overview, we'll have a discussion about the level of neck nodes, pattern of spread, a bit of about the evaluation, types of neck dissection. We'll also touch a bit about an N0 and N+, a bit about on morbidity, as well as a bit on sentinel node biopsy. It's not in particular order, just give you a better overview of what we're going to talk about. Levels of neck nodes, this was described by Dr. Shah, of course, where this helps us both in communication as well as it also kind of helps us in defining where the nodes tend to occur, and also kind of helps us. It also helps us in reducing the amount of neck we need to address and which levels we need to address depending on the site of disease. So it was divided into 6 levels. 6 we don't need to touch because it's more related to thyroid and larynx and hypopharynx. So 1 to 5 is what we are mostly concerned about. Then subsequently level 1, 2 and 5 are divided into 2A and A and B level to further define the criteria and how to go about the neck. And this is the pattern of spread which we expect. This is in an N0 neck, that is when we clinically we don't see a node in the neck, where most likely we can expect an occult nodal metastasis. In a tongue, it's more likely in 1, 2, and 3, a little bit in 4, but buccal mucosa, it's mainly usually in 1 and 2. Whereas in the node positive, spreads, you see them in level 4 is much higher in tongue, and some amount increase in 3 and 4 in the buccal mucosa. The staging, this is the latest AJCC staging. You see that now they have given a priority for extranodal extension. So if any node comes as extranodal extension is positive, directly goes to a stage 3B. This has probably been the most prominent change from the previous staging system. This probably we have heard right from the beginning, what a radical, modified, selective, extended. And what the classical teaching was, you remove everything which you can see in the neck, level 1 to 5, you throw in the sternocleidomastoid, cut out the jugular vein, you take out the spinal accessory nerve for good measure. Then they tried to modify this obviously to reduce the morbidity, but that started extending to some kind of confusion. What extra was not to be removed, whether the spinal, whether the jugular. That led to a lot of confusion in your communication, not just within your department or probably across the globe. So selective was So this is probably what we do with currently. Selective neck dissection, you define what levels you're going to take, avoid all those alternate nomenclatures to create confusion, and if any extra lymphatic structures are going to be removed, you just mention. That kind of simplifies the definition and also helps in communication between you and probably others. But despite all this, despite going into selective, there is a lot of morbidity associated with this procedure. It's not just removing the lymph nodes, everything is fine. It's still a tough procedure. You have a lot of these complications. You can see there's a big list, right from hematoma, right up to blindness probably. So what have we done to kind of reduce this neck dissection, your morbidity? So first was obviously to try and do more selective. If you look at this, the morbidity initially was around 18 to 77% with an MRNT, reduced to around 20 to 30%, but still there, selective neck dissection, and 20% of patients probably have persistent dysfunction. So we'll see what probably can be done to reduce this, but I don't think that's part of this discussion, so I won't go too much into detail about that. So next, coming to evaluation of the neck nodes. So if this is what evidence we have, if you look at it, the clinical examination gives you an accuracy of 78%. You will probably throw in a CT scan along with it, you get it up to 90%. And best is obviously if you remove all the neck nodes, then you know where the nodes are. So this is another study which looked at it. It showed that USG guided FNAC is probably the best, but then that's adding another invasive procedure to it. So whether it's preferable, you can probably just go ahead with a CT and a neck evaluation, which probably gives you an equivalent. Coming to the management of the N0 neck. So you have a patient, you have evaluated the neck nodes, you've probably not found any neck nodes clinically. What are you going to do the neck? Should you observe? Should you treat for this patient? So let's look at the arguments for both. So if it's an occult nodal metastasis, there is an N0 neck, you probably have higher risk if it's a tongue, floor of mouth, T3, T4, yes, definitely infiltrated, it's a thick tumor. These are all probably risk factors for expecting occult nodal metastasis. So what are the drawbacks for observation? We assume that, we're going to observe this patient so that we keep a close follow-up. As soon as we find the nodes, we'll excise it. But the reality is most of these patients, when they turn up, they have an N2 or a greater nodal disease, and we are not always able to salvage these patients, and they probably come in a higher stage and the survival drops.
So these were the arguments which were probably put forth in 2005 for ENT and against ENT. So that all these arguments, of course, came to naught when finally this paper was published by the Cruz and team from TMH, where they did the randomized control trial where they did elective nodal dissection for T1, T2 oral cavity cancers, and the primary endpoint they looked at was overall survival. And that kind of said that put everything in favor of elective nodal surgery in oral cavity. So what about upper alveolus? Does it equally match? I would say around 37% to probably 40% to other sides of the oral cavity. So there is a similar risk. So if you have an upper alveolus disease, you probably should address the neck. What about the extent of neck dissection? You have a tongue primary issue. There is this controversial paper. I would say controversial probably because it's probably the only paper which gave such a high level 4 nodal metastasis in tongue and floor of mouth cancers. Questions whether they actually cut the specimen properly or not, who has put. But yeah, so based on this, we now define our extent of neck dissection as whenever we have a tongue or a floor of mouth, we have to do address level 4 also. So to summarize N0 neck, we would say that selective neck dissection is recommended for early oral squamous cancer. Elective neck dissection definitely improves the survival, and you have to address level 1 to 4 in tongue and floor of mouth disease till we get better evidence for that. What about the N plus neck? Can we reduce the morbidity? Do we need to do R&D? Do we need to do MRND? Selective neck? Sentinel anyone? So let's see what we can do. This was a publication. There were not many cases, as I was say around 138 cases, which was published by the Brazilian Head Neck Council, where they compared SOHND with MRND and found it was more or less equivalent. So they concluded that yes, probably suprahumoid neck dissection alone could probably be considered for the N positive. Then there was this meta-analysis. When the number of studies which were selected, most of them were retrospective. They had very biased follow-up. Not everything was equal. So they also had a question was maybe we could probably do a selective neck dissection in those. So to conclude, still now, till want of better evidence, MRND is still recommended for an N plus disease, and selective neck dissection may be considered for select cases. We do have an ongoing trial, but I don't know when that will be finished for selective neck dissection in N plus. Next, selective. What can we do to reduce more? Can we go even more lesser than a selective neck? Sentinel lymph node biopsy has been done a lot in other sites for cutaneous melanomas and breast cancer. So we tried, why not do it in the head and neck? So why? Because elective neck dissection, you see, most around 70% of patients probably don't have a node. So why do you want to go ahead and give them all that morbidity? Can't we try with the sentinel node? This, based on the same principle, there's probably an orderly drainage from this tumor to a sentinel node, and that's probably the first economic. If it's come positive, then go ahead and test it. If it's not, then we can just probably observe it. So what do we need to do for that? This is probably how the lymphoscintigraphy procedure is done. They inject the tumor, then the patient takes the scintigraphy, they mark out the sentinel nodes. You can also use an intraoperative gamma camera. Just that particular node is removed. And that's sent for frozen section, routine sterile sectioning, cytokine, AHC, PHC, PCR. And if it's positive, then go ahead. Yeah, so this shows the INC, which you can see that, and that's actually in slide. So this is also another randomized trial. This came out from the Japanese group, Hasegawa. They showed that, yeah, it's I would say it's 138 they did ENTs and 137 SLNPs, and if it came positive, they did a same sitting, they did a neck dissection, or they did a second look neck dissection. But one, I would say, controversial thing, their non-inferiority margin was around 12%. Question that. There is also meta-analysis which say, yeah, probably SLNP could be considered. So why not do SLNPs for everyone? Yeah, we could probably consider it. T1, T2 oral cavity cancers. Quite a few centers probably do it routine, not out of trial settings also. Although they're limited to their tongue cancers, it's quite highly sensitive. But the downside is, yes, the patient will probably require an additional procedure. If it comes positive, then you have to probably take him up secondly for another setting of neck dissection. And you also need the facilities. Serial sectioning takes a lot of labor-intensive work, and also you need to have a facility of frozen section, lymphoscintigraphy. These factors probably limit sentinel node biopsy to probably high volume centers and probable cancer centers. So after all this, do we still have a role for R&D where we'll move everything? Yes, R&D is still there. It does have its select indications. These are the listed. I don't need to go through all of it. But yes, entry nodal disease, and where it's fixed to all structures, you probably will have to still do resort to R&D when you need to do it. Adjuvant therapy, specific indication when it's lymph node positive, better to give radiation. And when there is extracapsular extension and positive margins based on this combined paper of honor, we do give it in positive margins and extracapsular extension. So to conclude, the management of the neck is important to determine the outcome. Elective SND is still recommended for N0 neck. MRND is for node positive neck, and they want better evidence. Sentinel node biopsy, trial setting, maybe in select centers, yes, it's probably done routinely. Shoulder dysfunction is still a major morbidity, and we need to decide what best we can do to reduce the functional morbidity which we get from neck dissection. Thank you for your patience.
Thank you so much, sir, for that enlightening speech and talk. We now shall proceed on to the panel session next. Now, prior to beginning this session, any questions which you would like to ask regarding the previous talks, and the panel shall be accommodated after the first panel. The next panel discussion, the topic of that discussion is oral potentially malignant disorders and early oral cancers. In order to moderate the specific panel discussion, may I request Dr. Vikram Kekatpure, Senior Consultant, Department of Head and Neck Surgery, Tata Medical Center, Kolkata. But prior to that, before I give the podium away to the moderator, may I request? Oh, okay, so sorry. Dr. Srivastava.
I just wanted to make one point based on the previous presentation, wherein in one of the slides, in management of N plus neck, the Brazilian study was quoted. Just to put, just to clarify, that randomized trial was for T2, T4, clinically N0 neck.
It was a very controversial trial. I looked at very few numbers also. It's not a very...
No, the message is that that trial was for clinically N0 who turned out later to be N plus whatever, but it was not for N plus.
It wasn't a proper... Yeah, it wasn't a proper...
Yeah, so the question there was whether SND can be done was in comparison to MRND in clinically N0 neck, and then in that small trial they said that SND is good enough in T2, T4 oral cancers. That was the only message that can be conveyed from that trial. I just wanted to put that point. Thank you.
Enlightening discussion. We shall now proceed on to the panel discussion. May I request the panelists to kindly approach the bench as I read out your names. Dr. Poonam Joshi, Professor, Department of Head and Neck Surgical Oncology, ACTREC, Tata Memorial Center, Mumbai. Dr. Manish Goswami, Deputy Director, Surgical Oncology and Senior Consultant, Head and Neck Surgical Oncology, Medica Cancer Hospital, Siliguri. Dr. Shatandru Roy, Junior Consultant, Department of Head and Neck Surgical Oncology, Medica Cancer Hospital, Kolkata. Dr. Supreet Bose, Senior Consultant, Head and Neck Surgical Oncology, Apollo Hospitals, Kolkata. We are skipping that. Dr. Vaibhav Singh, Consultant, Department of Head and Neck Surgical Oncology, NSCRI Hospital, Kolkata. Dr. Manu Matthew, Assistant Professor, Radiation Oncology, CMC, Vellore. And Dr. Shubhalakshmi Sen Gupta, Head Consultant of Oncopathology, Medical Lab Advanced, Medica Cancer Hospital, Kolkata. May I request the moderator, Dr. Vikram Kekatpure, to kindly take over the podium. Thank you.
Namaskar. First, congratulations to dear Saurav and Harsh and the entire Medica Oncology team on inauguration as well as putting together an excellent scientific program. So, my job today is to discuss few points about oral pre-malignant lesions and early oral cavity cancer, and we have excellent panel here, and I look forward to having a very interactive session. There are very senior guys sitting on the floor also, and please feel free to participate. So I think that's where the real problem of oral cavity cancer is. Still, third of our population is using some or other form of tobacco, and if we see West Bengal and the northeastern states are higher on the median side of the tobacco use in the country, with Tripura being close to 2/3 of population using some or other form of tobacco. But the good part of it is, there is the carcinogenesis of oral cavity cancer is fairly well known, right from the chromosomal to the clinical pathway, and I'm sure the panel is going to enlighten us about this second aspect which I wish to cover. And the third part is the outcome. Dr. Prabhash also spoke about it, and we've been reading that the outcome has not changed over years, but fundamentally what is there, that stage 1 and 2 are doing good, and stage 4 and 3 and 4, and it's possibly no-brainer. And that's where we are going to focus today, how we can further improve the stage 1 and 2 outcomes. So let's start with some case scenario. I have these two patients, 1 and 2 here, where we have a patient 1 is a 45-year-old female presenting with a burning sensation in the mouth for 1 year, has been chewing tobacco for many, many years, has no other comorbidity. And then other one is a male patient, both smoker and gutka chewer, and is a diabetic with on oral hypoglycemic agents. So let's start with our home faculty. What would you do? How would you proceed, Shatal? The question is, do all the pre-malignant lesion like this require a biopsy, or what should be our first line of treatment?
Good morning, everyone. So I think first the clinical evaluation will be very necessary, sir. Whether to discern if I find any areas of higher suspicion where I would be looking for, I would be more concerned about the second picture where there is more of a reddish or a pinkish aspect to the lesion. I would be more concerned if I find if any raised everted edges or induration in my lesions. So given both the scenarios, I would be comfortable going ahead with an initial biopsy from the most representative part to be sure that represents, gives me an idea about what we are dealing with.
Wonderful. I think he's made a very pertinent point. So he's going to look for any areas which are more suspicious. The first one is more of a homogeneous leukoplakia, while the second one is a erythroplakia with a, maybe posteriorly more of a speckled leukoplakia. And he's going to look for a possible site for biopsy. So my question to Vaibhav is, Vaibhav, do all leukoplakias require biopsies?
Generally, homogeneous leukoplakias or small lesions we can observe, but the ones in the picture, I think we should be doing a biopsy for these, at least an incisional biopsy.
So you would do an incisional biopsy for both the patients?
Yes, yeah, in the first picture it's quite a big lesion. So yeah, I'd go ahead and do a biopsy.
So again, very important point. So he is going to do incisional biopsy. So remember that he is not talking about doing an excisional biopsy. So that's the important message, I think, for the students in the audience, that any suspicious lesion, always do an incisional biopsy before you make a diagnosis. Otherwise, the subsequent management in case of malignancy becomes very difficult. Vaibhav, I'll come to you as a last. Manish, so where do you choose to do a biopsy?
The most indurated part, and I will probably take a wedge because I believe the specimen who goes to the pathologist is important, and in this kind of pre-malignant lesions, this plastic which might be, the depth will have a importance, and will let the pathologist take a decision, so it should guide us better.
Right. So, Dr. Poonam, you had a point too.
Yes, sir. Actually, it is almost the same. Just to first one, sir, the question like when do we do biopsy? I just wanted to add one more point for the first slide. For the first case that the panelist said that even in the first case we need to do an incisional biopsy. That is to help us. So first thing, we know that first case is a homogeneous leukoplakia. But even though it is a homogeneous leukoplakia, the size is large, right? Rightly said. The other point is, which I can make out here is, so it is in the floor of the mouth. Is it in the floor of the mouth, or it is buccal mucosa?
No, both are buccal.
So it is in the buccal mucosa. So here the main reason here is the size, and we need to take a biopsy. But naturally it is a homogeneous leukoplakia, site is going to be difficult, and if we get a moderate to severe dysplasia, naturally we'll have to think, do we need to really treat it, even though the resection is going to be large.
Right.
So even for first case.
So I think we'll come to the biopsy report later. So Dr. Sengupta, we always have challenge where to take biopsy. So what is the pathologist, as a pathologist, you want in pre-malignant lesion? How should we do biopsy from, and what tissue would you like for an appropriate interpretation?
As pathologists, we sometimes feel difficulty in interpretation of a very superficial biopsy where we get only the stratified squamous epithelium, and we do not have the deep subepithelial tissue to assess the invasion. So we have to then hedge our impression, whether it's just to atypical spermoproliferative lesion rather than to comment whether it's an invasive malignancy or not.
Right. So I think that's a challenge for pathologists also to give a good diagnosis. So limitations are there when you have pre-malignant lesion. Where do you sample from? How much tissue do you send? Whether there is enough inter-observer variation also is a challenge, because one pathologist may say it's a mild dysplasia, somebody may say moderate, and so much of variation. So doing a biopsy also is a challenge. So that's where, whether we can use any diagnostic adjunct, Dr. Poonam, any experience of using any, so that we can choose the right tissue and which will help us to make the diagnosis. Is Harsh there? My timer is not working. Can you put the timer on? How much time we have?
It's the first time somebody is sitting.
It's not working. It's not working.
I'm retaining it.
So, sir, I think this role of non-invasive diagnostic methods, we know there is like a battery of these adjuncts. So, but if we go by the evidence also, personally, I would say I don't have much of experience because at Tataman Hospital, routinely we are not using these adjuncts. But I think that comes from the evidence, from the literature. We have a Cochrane meta-analysis in 2015, which has shown, in fact, there is an update up to the cases up to 2020, where around 8,000 cases were taken into that meta-analysis, and that has shown that the vital staining, which is used like toluidine blue to stain the most the area which is most likely to be the malignant, all those the vital staining, these other methods like the optical based methods, well scope, other things, they all have very poor specificity. Specifically, sensitivity range from like 60 to 80%, but the specificity is like 50% also. So the final call or the final message has been that they are not useful, and if you really have to do it, you have to do a biopsy so as to look for the moderate to severe dysplasia, but we know there are itself challenges.
So important point. So all these.
Sir, if I may add, I think we have to also consider the availability and the cost of these things.
Correct. So I think toluidine blue has been there for many years, but as Madam has rightly pointed out, how much they help us in choosing the right and making diagnosis, that still remains a challenge. But at some settings, these can add to your clinical judgment. But again, the availability remains a challenge. And now there are multiple newer adjuncts which are coming. Particular interest is OCT as well as confocal microscopy, and these are something in future which will probably help us to make right diagnosis. So how many of the audience would want to observe the patient one? Okay. Two. How many of you want to observe patient the second patient, the erythroleukoplakia? Show of hands. Nobody wants to answer. Very good. So I think we have a consensus. So how would we proceed? Should we do a laser excision or just do a biopsy? How do we do this? Yes, both.
The first patient probably I would observe, but I think it depends on how frequently the patient is ready to follow up. If it's a 3-monthly follow-up, which patient is ready to follow up, then probably I will observe. A second patient I would like to operate. I think a laser excision would be good enough.
Laser excision. And how deep you would take? Would you do a cancer surgery or just excision?
Just excision, not a cancer surgery.
Just excision. Anybody wants to differ on that?
I think I would agree with Sir or Manish Sir on this, that excision will be probably till the level of the buccinator muscle, not beyond that. I wouldn't like to go beyond that.
Sometimes even the muscle can be preserved.
Exactly.
Leukoplakia. So we agreed with the panel and we went ahead and did the excision, and this is the pathology report. The first one is the features are consistent with clinical diagnosis of leukoplakia, no dysplasia. The second one shows moderate to severe dysplasia extending up to the margins of excision. So what should we do now? The second one.
Scar revision, sir. We need better margins into the scar revision, sir. Because it's moderate to severe dysplasia, I'll not take chances and just do the margin revision.
Does everybody agree? Audience, he wants to revise the margin for the second one.
I probably won't do it. Primarily because we don't know where the negative margin is. That is one thing. What I would be more concerned about is number one, follow-up, good dental prophylaxis, and de-addiction.
Wonderful.
Sir, I almost agree with the panelist. The only point, I think there is some, I don't remember the exact paper, but there's some data to suggest that the kind of, even though we are talking about dysplasia, I think Madam will tell better, right? The kind of dysplasia we are talking here in does it the same as compared to those cases where there is a frank malignancy? So there is some difference in the two, even though I think I could convey that. So this is a case which is still a pre-malignant lesion, which has moderate to severe dysplasia. We know that there can be 30% chance of malignancy, but still it has come as dysplasia only. So is it the same situation as a case where there is a frank malignancy and severe dysplasia on the margins? There is some controversy on that.
So there is always a challenge when we are trying to chase the dysplasia, mainly because as we saw the carcinogenesis model, the genetic changes or the chromosomal changes might be well beyond the visible morphological changes, and it really becomes a challenge. I mean, there is no right or wrong way to decide, but generally we may find it difficult to chase dysplasia because it may still keep coming in a visibly normal mucosa. Is that right? Field cancer. Wonderful. So, as you are rightly pointing out, tobacco cessation and possibly chemo prevention are the option. Now, that is an important thing. When do you actually do chemo prevention, and does it work?
Something like how it was put across by you and Madam both regarding the use of the adjuncts. I think their role is still not clearly defined. So I think it's a very clinician to clinician motivated practice. But I think it's not something that is in regular practice per se. So I think at least we do not do that regularly in ours.
So yeah, that is basically one of the challenge. So just to summarize, the oral pre-malignant lesions can be divided into the low risk and high risk, and that kind of helps us to make a decision about when to biopsy, when to keep under observation. So generally, homogeneous leukoplakia, buccal in younger patient and non-dysplastic, you can possibly put it for observation, while high risk would be in the floor of mouth, erythroleukoplakia, speckled leukoplakia with large mutation burden probably are more high risk, and chances of malignant transformation might be higher. Does the panel agree with him? In the interest of time, we'll go ahead. Now, chemo prevention. There is just a huge list of agents which have been studied, and there are multiple talks. We even see ads coming about chemo prevention. That becomes a real challenge. How do we choose? So what is your policy in Tata's? How do we choose about the chemo prevention agent?
Sir, I think right now we are doing a trial. We are doing it in a trial setting, but as far as I know that we are not using it as a routine practice, because we are a big unit and there are several units, but as this thing we are not doing it routinely, but like Sataduru rightly said, the evidence is not very much in the favor, and we know that a lot of toxicities, especially with retinoic acid, and again rebound and relapse of the cases, and there are again none of these modalities has shown much response. So not much in favor.
Completely agree, sir. There is no much of evidence defending it. So yeah.
So I think most of the very well studied model is the vitamin A and vitamin A analog. It's a beautiful story how the science can be developed, but still comes back negative. But still it's a very, very elegant piece of science how the vitamin A story has been developed, from vitamin A, then cisretinoic, the high dose worked, then the low dose didn't work, and the final conclusion was it works but it cannot be used in clinical practice. But it's an elegant story how science should develop. So vitamin A has been tried. Our Indian data about curcumin is also there. So all of these have transient effect, but the problem with most of this chemo prevention is the durability of the response. And if somebody is using, there cannot be any controversy, but the challenges remains. Should we move to the next case, early oral cancer? Any questions about chemo prevention from the floor? Any comments? Prashant, Rakesh, yes?
The low risk and the high risk stratification. I think the other thing that probably can be added is the size of the pre-malignant lesion, more than 2 centimeters. Probably that could be in a high risk group, apart from what is listed. Just a comment.
Okay, yes. What?
So just to clarify, I wanted one clarification regarding that similar case that we discussed regarding the erythroplakia. So to get a severe dysplasia in a background of erythroplakia, let's say, and to get a severe dysplasia in a background of early oral cancer, would our approach differ per se in the fine?
Point is they are like we still need to find out, like I said, because this we are talking is still about severe dysplasias, even in the primary. This is not a frank malignancy which has breached the basement membrane. So does it behave the same way in like a case where there is an invasive carcinoma? So that also we need to have more data to understand, and like condemned mucosa, field cancerization, how much can we really chase?
Correct. So I think, to keep the things simple, as long as it is not an invasive cancer, we are not talking in terms of survival margins and other things. We are still in the pre-malignant realm. So in that way, we are still talking about just getting rid of the morphological changes rather than talking about the survival and margins. And that's where I think we need to deal with it. And of course, I think Harsh also wanted us to convey this message that let's try and find out more patient in pre-malignant level than getting it into cancer, right? Now, unfortunately, if somebody progresses to cancer, now this is our case too, 60-year-old male, no history of tobacco use, no comorbidity, has a non-healing ulcer at the extraction site of the last molar since 1 month time. Now, examination reveals a 1 by 0.5 centimeter ulcerative lesion without much induration, no palpable neck nodes. Right? Now, in such cases, post-extraction, non-healing ulcers which have been there, when do you decide to do a biopsy?
Non-healing ulcer, after extraction, I'll see the duration of the post-extraction. About a month. So yeah, that demands a biopsy. Also the clinical picture of the lesion.
So in general, I think for the students here, any oral ulcer which has not healed in 3 weeks' time warrants a biopsy unless we know the pathology of it. It's a trauma or some drug induced. In general, bottom line rule, a non-healing ulcer more than 3 weeks of duration, a biopsy should be done to rule out a malignancy. So similarly, a biopsy was done for this and it came back as squamous cell carcinoma. So how do we proceed? Manish?
So it's a very small lesion. Clinical examination, I would like to look whether it is indurated, no neck nodes. Even in ultrasonography, neck is sufficient, but for the sake of data, I think I will get a CT scan.
You will do a CT scan?
Just for the sake. It's not going to change my approach to the treatment.
Right. So I think Manish has directly pointed out ultrasound for neck or CT probably to assess for the neck nodes. As do we want to assess the mandible involvement in this?
Definitely, sir. It's that's why I think I would be more comfortable with a three-dimensional imaging, just to understand, because it's quite close to the bone and it's a non-healing socket. So it sometimes can be difficult to make out whether there is actually any involvement of the bone or not. So that needs to be clarified before I proceed with any decision making.
Wonderful. So we've not got Dr. Matthew in so far. Do you want to radiate any of the pre-malignant lesions? I've seen some radiation in southern India being done for pre-malignant lesions also.
No, unless and until in operable situations where there is no other treatment options.
Okay. Do you want to radiate this guy? It's tiny lesion.
No, but this location is in the alveolus and the RMT where we have the margins will be difficult and there's maybe a possibility of bone involvement. So if it's a well lateralized tumor, accessible location, we can discuss that option, but maybe not be a good candidate in this patient.
Dr. Sharmani doesn't seem to agree. Tiny lesion, T1 lesion.
Yeah, but I think it is amenable to surgeries. The simple reason I would send this patient for surgery is that we would get more information on the pathology of this tumor. So that is my main reason for sending for surgery. Of course, radiotherapy is a viable option, not to say that it isn't, but this kind of a lesion I would send for surgery because I want more information on the pathology of the tumor.
Wonderful. So
One thing I wanted to know, this lesion was in RMT, right?
it is in the last molar, extraction socket.
Extraction socket. So sir, all the more there is a reason to do CT instead of ultrasound, I would say. So if it is in RMT or it is in the bone, definitely we have to do a CT. Ultrasound probably will be suboptimal.
Okay. So what surgery you guys want to do? Quickly. We'll take one more case before we stop.
I'll do a marginal mandiblectomy with
marginal. So assuming that there is
no bone erosion,
on the CT scan, you think marginal is
sufficient.
Mainly because he's a dentate, you imagine a big mandibular height. What about the neck management?
I'll do a neck dissection.
You will do a neck dissection. Selective neck dissection.
Selective neck dissection. Yeah.
Right. And then if we get more information, any node positive, we discussed this shoulder dysfunction. Kapila had just mentioned any questions we can take about the neck dissection part. But I think standard would be to marginal with a selective neck dissection. Now with De Cruz's paper coming from Tata, I don't think there is many confusion. For general practice, keep it very simple. Even for early stage cancer, a selective neck dissection is good. It should be done. We can change individualized treatment, but as a general message, neck dissection should be done. As Dr. Sharbani was also pointing out, we get more information out of the pathology. Some of these may have extranodal spread even if there is a small thing. So we did marginal, closest margin is 8 millimeter, 0 of 29 node involved. Any role for radiation? T1 and 0.
I'd like to know other factors like LVA, PNI, WPOI, all those things also can make a difference. Depending upon, but based on this report alone, I have not seen any indication.
No need for any radiation. Great. Now let's take one radiation before we conclude. Now this is a patient showing bilateral angle of mouth squamous cell carcinoma. Both angles of mouth has SCC lesion. One side is bigger, other side is smaller. Surgeons, who do you want to operate? No, I'm asking, do you want to operate this?
So I will be asking Sarbani madam if there is any chance of giving brachytherapy as it is in the angle of the mouth, that too bilaterally. The resection is going to be bilateral, but naturally we have to see the neck status. I assume it is N0. Otherwise, naturally it is going to be resection with appropriate reconstruction.
So we recently have done a brachytherapy for a lip lesion, but that patient had undergone surgery twice, was radiated. So I think that modality I would like to preserve for patients who are not primarily for surgery. So twice operated, radiated patient, 14 years, has come back with a lip lesion, P1, we have the
Recommended?
I think as per the appearance, it looks like an ideal candidate to look for a brachytherapy option because it's much lateralized in the angle region, much away from any bony structures. Ma'am?
Yeah, so this lesion, especially the lesion on the right, in this case, on the left, I think it's just superficial at the commissure, right? So I would actually, for the right lesion, evaluate him properly for the thickness or rather the depth, and also evaluate his neck appropriately. If everything is negative and it's not very thick on palpation and that's the only extent, both of the lesions are actually amenable to brachytherapy.
Right. Ma'am, just one point. I remember having discussions with you regarding the similar kind of cases while in TMH, and you always used to say regarding the skin involvement, which used to be apart from the neck nodes. So in the right lesion, would you be comfortable because it's coming very close to the skin? So would you be comfortable with going ahead with the
You know, the right lesion involves the skin by virtue of its location. It's not a through and through penetration. It's actually the disease is coming onto the angle of mouth. So when we do brachytherapy, now if this lesion is really thick and it's a thick lesion, I would sometimes also combine this, make it a combined modality in terms of radiotherapy. That means I would do external beam plus brachytherapy. So if this is really very thick, what I would also do is perhaps make external beam radiotherapy with small portals, address just the 1B2, and then consider the brachytherapy boost. But this skin involvement is not a through and through involvement, it's by the extent locally.
So I think the important issue here is the commissure is a difficult area to reconstruct, and if you have a bilateral, the surgery, although seems very simple and easy, can cause a lot of functional morbidity. So probably these are the cases where you would electively consider radiation as a primary modality than surgery. So this is just a case in point, we can debate about this. But if you have a similar lesion, probably bigger lesion with more skin involvement, possibly brachy, and as Madam had pointed out, is a very good option, mainly to preserve the function. So our time is up. Okay, so finally I would just say one thing before we conclude our early panel discussion, is that tobacco control is primary. We need to focus on tobacco cessation. We need to do a lot of screening and prevention, and also multidisciplinary management of the early oral cancer, and that's when we are going to reduce the burden and improve the outcome. If there are any questions, we'll take it. Otherwise, we would like to thank the panel. Thank you so much.
Thank you so much for that excellent discussion. Are there any questions from the previous talks which anyone would like to ask the speakers? You can go ahead as of now. Fine, we go ahead and proceed. Now comes the time for the next talk. The talk is on compartmental excision for T4B buccal alveolar cancers, and this is going to be presented by Dr. Shivakumar Tyagarajan, Professor, Department of Head and Neck Surgical Oncology, Tata Memorial Center, Mumbai.
Good afternoon to all, and as the slides just open up, I would like to thank Harsh and Dr. Saurabh for having me here and congratulate them on this occasion as well. So this talk is basically on compartmental excision of T4B lesions. So I'll just stick to that. And so we know that GB, gingival-buccal sulcus cancers are the most common subtype of oral cancers, and masticated space involvement in advanced GB cancers is staged as T4B as per our staging system, and traditionally T4B are considered to be inoperable, but we all know that in oral cancers, T4B, not all T4Bs are inoperable. There are quite a good percentage of them whom we treat them curatively, and they do well as well. And surgery is definitely an option for these patients, and we have alternative options for them, as was mentioned by Dr. Kumar Prabhash in his presentation as well. So T4B, again, when the masticated space is involved, we have the the sigmoid notch. We use that as a indicator to say whether the low ITF or the high ITF is involved, and we probably base our treatment decisions on that, and also the prognosis varies as was shown by the paper by Liao and colleagues. And that's the representation of one of the T4B lesions where the masticated space is involved. We're going to talk about this kind of patient where it is upfront resectable, and that's what we're going to see. And the compartmental resection, actually stems from the concept of compartmental resection from the musculoskeletal lesions, wherein the idea of tumor that tends to spread through the area of least resistance, where the facial layers try to give some sort of a resistance to the tumor spread. So this is just not a comprehensive review of literature, but just a review of literature showing the compartmental resection for T4B lesions mostly, where upfront surgery was done predominantly in most of the diseases except for a couple maybe, but upfront surgery for T4B lesions. You can just note here that the 2-year overall survival is averaging anywhere between 50 to 55%. That is pretty good survival for a T4B kind of a cancer. So definitely T4B oral cancers can be, when treated appropriately, they do well. So this is just a video, it has a voiceover, so we'll just show it's an ITF clearance. Compartmental clearance essentially means that we do the resection of the mandible, upper alveolus, and clearing the ITF tissue. Just a brief video on that. Can you increase the volume there, please? Is it possible? Volume. Okay, it's okay. I will just. Okay, so here we just need to know the difference between the ITF and the masticated space, wherein ITF does not include the mandible, it just is the the masticator lateral pterygoid muscles, where the masticated space includes the masseter and the mandible. There's a subtle but a definite difference between infratemporal fossa and the masticated space, which we need to address, and that is what is shown here. The red dotted line is ITF, whereas the yellow dotted line is the masticated space. This is again showing the boundaries of the masticated space at the skull base, wherein the anterior is the posterolateral wall of the maxilla, laterally the zygoma and the part of the mandible, medially the pterygoid plates, posteriorly the posterolateral skull base. And this is the facial lined area where it is attached superiorly to the temporalis muscle and the skull base, and laterally to the pterygoid spine there. And this we have discussed the paper by Liao's, where they have divided the high ITF into the supra and the infra notch, which does make a difference in our decision making and the prognosis as well. And this was further subdivided by Pillai and colleagues in class 1, 2 and 3, depending on how further up the disease is going in. And it's a very useful classification to have in mind, where predominantly the class 1 and class 2 is resectable, which we can consider for surgery. And this is a case that we're going to show. It's a 56-year-old lady with comorbidities. She had a T4B disease, so it was considered upfront resectable because the high ITF was not involved. This was the surgery that is going to be done, wherein the patient was then reconstructed appropriately. We're just taking a skin incision here through the platysma, and this considerable amount of skin that had to be excised because the skin was fungating out, and we're just raising this skin flap in the subplatysmal plane here. And we've just so what we do is essentially we use this lint piece over the fungating lesion, not to just handle it, because we do see sometimes there's a theoretical risk of implanting, so that is taken care of. Here we just taking the 1B along with the specimen, so the facial artery is clipped for the subsequent microvascular anastomosis. So the mucosal incision, once we have taken and we're raising the flap anteriorly till the area where we're going to take the bone cut there, which is just beyond the canine, the mental foramen. Here we're raising the upper flap, and we're raising the flap, taking care that we do not go beyond the zygoma there. Because when we do that, when we go up above the zygoma, you can damage the zygomatic branch of the facial nerve, and the patient can have facial palsy at present. So here, that's what we just palpated to make sure that we are not going beyond the zygoma. That's the parotid duct. It's very important to identify the parotid duct and ligate. Otherwise, it will be very troublesome in the post-operative period for the patient. There's consistent collection and which can get infected subsequently. So now, once that is done, we cut the masseter muzzle, hugging the zygoma at the lower part of the zygoma, so that you take the entire masticated space as much as possible. So we are hugging the zygoma and just cutting it superiorly. And posteriorly, we delineate the posterior border that will be seen here. We're just cutting the masseter there. That's the zygoma that's being shown there. And then you connect it posteriorly to the, here we are coming along the posterior border of the mandible, and we're just connecting the two masseter cuts there. And we'll be just exposing the condyle there as well. So that would be the region of high ATF. So once that cut is taken, now we are trying to expose the internal maxillary artery there. So before we proceed any further, we try to clamp the internal maxillary artery. That would help in minimizing the bleed while doing the infratemporal fossa clearance. So once that is done, then we proceed with the further surgery here. So this is the temporalis muscle which is being cut as high as possible. Sometimes we do say that you expose the coronoid process, but in such cases, it's better not to expose because the muscle, the bone can be eroded higher up, so you can keep a cuff of temporalis muscle as a margin as well. So I usually tend to go as high as possible and cut the muscle. And that's essentially what is being done, and the retroantral fat pad is also taken down along with that. That's exactly the high ITF that is shown there, medial aspect of it, so where we have just got all the tissue from that area downwards. So once we have released all of this, it is important to do this first, because if you take the bone cut, the mandible will retract higher up and you won't be able to do all of this if you take the bone cut up front. So once that is done, take the bone cut and then proceed posteriorly towards the, to take the medial cut, because again this needs to be taken at this point so that we can have a proper visualization of the margins that we are going to take medially. Sometimes if the mouth opening is not good, again you will not be able to see it better. So once the medial most mucosal margin and the upper alveolar mucosal margin is taken, then we do the upper alveolectomy. We do the preparations for doing an upper alveolectomy where the soft tissues attached to the upper alveolus is cleared to take the bone cuts. You can see that we are trying to take all the high ITF tissue closer to the pterygoid plates down as much as possible. There you can see the entire soft tissue is pushed down, attached to the upper alveolus. So this bone cut I would tend to take after all of this is done, because if you do this up front, again there'll be bleeding and it might make your surgery a bit more cumbersome. Once that is done, we need to take the release the medial pterygoid muscles as high as possible, closer to the pterygoid plates and the hamulus, so that as you can see here, the entire pterygoid plate is being, the muscle attachment is being released. So that part has to be, the medial part of this ITF clearance has to be done here at this point. And once we do this clearance, then we have to go back laterally as well. So at this point, I tend to do it with a bipolar. You can use whatever tools you want. You can use it with a thunderbeat as well. Now here, once we have done that medial soft tissue release, we are again going posteriorly, and the capsule of the DM joint is again released, and we are trying to take down all the high ITF tissue along with the periosteal layer. So once, as you keep doing this, the entire roof of as you can see that the bone, the skull base is exposed there. There you can see that, and so we have cleared medially. We have cleared it from the posterior aspect as well, and the skull base is exposed. The entire periosteum is taken down, and all that that is holding the specimen now is just the mandibular nerve at the foramen ovale. You can see that there. The mandibular nerve will be seen, and here while using suction at this point, you have to be careful. If you just use the suction without any rationale, you will end up having 2 liter blood loss. So you need to be very judicious about it. And we just cut the mandibular nerve, as you can see, higher up at the foramen ovale, and take and achieve hemostasis at the end of it. So the entire thing comes on block as one specimen. You just, once that is out, you assess for the margins, the soft tissue, mucosal as well. And we do have a practice of sending it for frozen whenever we have doubt, and that's the skull base. Once that is dissected, you can see the pterygoid plates and all that. That's the reconstruction done subsequently. And thanks to the team who helped me put this video together. that's in short about the the surgical technical aspect of the compartmental resection. Before I conclude my talk, I'd like to invite you all to the OncoSurge, which is to be conducted between 23rd to 25th of November, where we will be demonstrating the basic head surgeries in surgical oncology, including a day dedicated to some of the head and neck surgeries as well. Thank you for your attention.
Thank you so much, sir. We now proceed on to the next talk. The talk is Adjuvant Therapy in Oral Cancers with Advanced Prognostic Factors, and this shall be presented by Dr. Sarbani Ghosh Lashkar, Professor, Department of Radiation Oncology, DMH, Mumbai.
Good afternoon, everybody. I begin by thanking Shayan as well as Saurabh, Harsh and the entire team at Medica for this invitation. Shayan asked me to talk on a very controversial topic, and though he called it advanced prognostic factors, I'd actually put them as intermediate or indeterminate factors, simply because there ceases to be any clarity on what do you do with the presence of these features on the histopathology report. So I'll try my best to present as to how I have assimilated the information and how I apply this in the clinic. So the choice of treatment in any cancer for that matter depends on considerations of disease control, site, extent and stage of disease, as well as the anticipated functional and cosmetic outcomes, and very importantly on the availability of resources and expertise. And as far as this topic is concerned, it actually is multidimensional, because this is as good as your radiologist is, as your pathologist is, and thereafter come the other clinicians. So this is a very important thing that we have to keep in mind, that is the availability of resources and expertise. Now, in early stage oral cavity cancers, most patients have a 5-year overall survival of anywhere between 75 to 85%. However, about 15 to 25% are aggressive tumors and require adjuvant therapy. Various high-risk factors have been shown to guide adjuvant therapy, and recurrence is seen even in the absence of those high-risk features which we have conventionally known, and this is essentially dictated by the presence of certain other adverse histopathological parameters. So what information do we need when we have to decide on whether there is a need for adjuvant therapy or not? Preoperatively, we have to be able to achieve an R0 resection, so that lies in the court of the surgeon. Cosmetic and functional excision whenever possible, extent of resection both at the primary and the neck. Very importantly, in the preoperative phase, we also need to have access to the imaging of the patient who is being treated. Intraoperatively, we need to be able to achieve the above. We need to also document if there were any surprises at surgery, need to understand the anticipated morbidity and the type of reconstruction. And post-operatively, of course, we need to know the anticipated morbidity, the course and stay in the hospital, and of course, anticipate the need of adjuvant therapy based on both the pre, intra-op, and post-op findings. So again, the pathologist here plays a very important role. And I'd like to draw your attention to the synoptic reporting system that we have at the Tata Memorial Hospital. What we have is a summary report and a final detailed report on all patients with head and neck cancers, and I believe it is present in other sites too. Now, the factors that you have on my left are actually those factors that definitely deserve a mention, especially in early oral cavity cancers, because they talk about the tumor location, the tumor epicenter, the size, maximum depth of invasion, predominant pattern of invasion, the worst pattern of invasion, involvement of the adjacent structures like the skin and the mandible, presence of lymphatic emboli, vascular emboli, perineural invasion, and of course the status of the margins. When you come to the neck, you have to know the extent of the neck dissection that has been done, and the lymph node yield at the various levels in the neck, and also of course their involvement and the proportion of involvement at every level whenever feasible. Now, with this information in mind, we need to then decide upon the need for any further therapy. So now we will also address the issues of adjuvant radiotherapy, the rationale and the evidence. We will also talk about what is the optimum timing and for what indications do we need to do this. We will also talk about the rationale and evidence for the dose, when to do it, and then we will decide about whether there is a need or not. Classically, we all know about these major factors, and we do know that adjuvant radiotherapy or sometimes even adjuvant chemoradiotherapy are needed for these major factors. But what will be the topic for discussion today is what about the presence of these adverse features that we have in the form of perineural invasion, depth of invasion, lymphovascular invasion, worse pattern of invasion, and tumor budding, though I will not be talking about tumor budding too much today. Now, coming to perineural invasion, most of us in the audience will be aware of what the definition of perineural invasion is. That is involvement, circumferential involvement of a named nerve or any nerve within the tumor by the tumor. So in this paper by Chin, what they looked at was 88 patients with oral cavity cancer with pathologically N0 status. All patients had undergone a minimum neck dissection of levels 1, 2, 3, which is the classically described neck dissection. 23% of these patients had PNI. Of these, 70% underwent adjuvant radiotherapy. There was a significant difference in local failure, but not distant or regional failures in the patients who had PNI. PNI was also seen to be associated with a worse disease-free interval and local regional control, with LVE being the worst for disease-free survival. Those patients who had PNI and underwent adjuvant radiotherapy had significantly improved disease-free interval and local regional controls, but no impact on overall survival. It was found to be an independent indicator for adjuvant radiotherapy in the absence of positive lymph nodal disease. Now, this is experience from the Tata Memorial Hospital, Deepa's paper, more than 1,500 patients, where they found 20.3% of the patients had PNI, more so in the tongue. PNI was found to be an independent predictor of disease-free survival and overall survival. Node-negative patients with PNI had better outcomes when given adjuvant radiotherapy. So between the two papers, you realize that there is in this paper an impact on the overall survival, where in the previous paper by Chin there wasn't. And of course there was an impact of using adjuvant radiotherapy, though PN0, in both papers. However, if you look at literature on the whole, what you will also realize is that the presence of PNI is actually a predictor of higher T stage and can predict for regional recurrence. In the absence of other adverse features, that is, when you have PNI as the only adverse feature on histopathology, what you need to know from your pathologist is also whether it is a named nerve or a small nerve, whether it is intratumoral, peripheral, or extratumoral, the number of foci, that is, whether it is multifocal or unifocal, and another important thing, of course, is whether today our pathologists, if you saw in the report, also talk about the density of PNI, that is, the number of sections in which they have seen PNI divided by the number of sections that they have evaluated. So my recommendation on the presence of PNI as the sole factor would be the above, and discretion would be warranted in the use when PNI is the sole adverse feature. The next thing is, of course, talking about depth of invasion. This is a multicentric retrospective study, 3,000 plus patients with oral squamous cell carcinoma, treated with curative intent at 11 comprehensive cancer centers, with a median follow-up of 40 months, assessing the impact of DOI on disease-specific and overall survival. The mean and median DOI were 12.9, that is almost about 13 millimeters, and about 10 millimeters median. On multivariable analysis, DOI was significantly associated with disease-specific survival, no institutional prognostic heterogeneity. So when you have these values and You saw DOI increasing. There was a definite impact irrespective of the institute where they had been reported from. And it resulted in an improved model fit compared to the T category alone. That means it also was discriminatory. Now the other point is that this is what you saw. As the DOI increased, the disease-specific survivals also became different within a particular T category, which simply goes to say that DOI has a definite impact on outcomes, especially the disease-specific outcomes, even for early-stage tumor. So now, of course, we know that this has made it to the AJCC, the 8th edition of the AJCC, and this was, of course, data from the Princess Margaret and the MD Anderson. However, what we do not know even today is that there is no definite cutoff. The only evidence that we have is that it is a definite adverse prognostic factor, and the impact of DOI in the presence of complete, adequate surgery and adequate neck dissection is really not well known. So what do? We really don't have an answer. Some people consider 0.6 as a cutoff, some people talk about 0.4 as a cutoff, but definitely what we look at is that anything about 0.9 cm, we definitely do adjuvant therapy. Also, when we look at subsite, we have a lower threshold for employing adjuvant therapy for the oral tongue as compared to gingivobuccal complex cancers. Now coming to the issue of lymphovascular space invasion. Now again, this is a paper by Cassidy, 180 patients from 2003 to 2013. With LVSI, there was worse locoregional control. If you use adjuvant radiotherapy, there was an improvement in locoregional control. And they concluded by saying that lymphovascular space invasion in patients with node-negative oral cavity cancers treated with upfront definitive surgery is associated with worse locoregional control, overall survival. Node-negative oral cavity cancers warrant consideration of further adjuvant therapy. Now, what we do know that there is a significant association between various disease-related outcomes in the presence of lymphovascular space invasion. But it is not statistically associated with local recurrence, neck recurrence, and distant metastasis. But by itself, whether it continues to remain an independent prognostic factor, we really don't know. We don't have an answer. Now comes the Margaret Brandwin-Gensler staging system, because this is one of those very early on staging systems that considered things beyond the margin and E&E, and that is essentially a system that was developed on the presence or absence of perineural infiltration, worse pattern of invasion, and lymphocytic infiltrate. What they did was to assign scores to the various parameters, which was worse pattern of invasion, lymphocytic host response, and the presence or absence of perineural invasion, and you can see the scores that they have given. Now, patients were divided into low, intermediate, and high risk based on the total point scores. So what you had was a low when you had none of these parameters, intermediate when the total scores were 1 or 2, and high when the scores were more than 3. And there was a definite discrimination between these various group categories, and hence they went on to say that, of course, beyond the cut margins and the presence of E&E, we definitely need to look at other parameters. This is again another paper that actually looks at all the parameters together, essentially tumor budding, depth of invasion, other histological risk assessment, and cancer-associated fibroblasts. On multivariable analysis in these 233 patients, what was found was a depth of more than 4 millimeter, tumor budding of more than 5 cells in the invasive front, along with the POI was significant predictors of disease-specific survival and need treatment intensification. So we had actually written a paper a long time back, which was actually a review of all the literature that was available on at that time. And what we did realize that when it came to LV or LVSI, it was equivocal evidence. In PNI, we had some unequivocal evidence, and for close margins, of course, it was unequivocal. Now comes a very new entity, that is the pattern of invasion. The pattern of invasion actually has to be interpreted on two fronts. One is the implications of margin and then the pattern of invasion. And the other thing is, of course, what is the prognostic implication of the worst pattern of invasion, or WOI of 5. Now you need to also understand that it is important for us to use a definition that actually is standardized. Now in this paper they have defined WPOI as the presence of satellite nodules, extratumoral perineural invasion and or extratumoral lymphovascular space invasion in low stage node negative oral cavity squamous carcinomas. And what they found in these 160 patients who were staged as far as the TNM7, that the univariate analysis showed WPOI 5 and the 3 constituent components. Please remember this, that is tumor budding, extratumoral extensive PNI, extratumoral LBI were all important with significant for disease-specific survival and overall survival. And on multivariable analysis, satellite nodules and extratumoral LBI were independently associated with overall survival. Post-operative radiotherapy and non-tongue subsite was significantly associated with overall survival, and this is something that is important, and this has a definite prognostic implication in patients with early stage oral cavity squamous cell carcinoma. So if you look at the information, non-tongue primaries versus tongue itself, it was important. Then if you had non-cohesive pattern of invasion, again it was an important factor. Any PNI was important, but the presence of extratumoral PNI was what was really significant. And again, extratumoral LBI was significant, and WPOI of 5, when we considered all these parameters for definition, was significant for all these patients. Now the other thing, as I said, was the presence of WPOI and what should be the status of the surgical margins. Why is this important? Simply because when we talk about WPOI, you're talking about tumor islands or buds of tissue that are away from the main tumor, which simply means that it has an implication, that the cut margin status has an implication. And this study of 772 patients, the retrospective cohort from Kowalski's group, definitely showed that when you had a WPOI of 1 to 3, perhaps 1.7 millimeters was enough. But if you had WPOI 4 or 5, you had to have a wider margin in these patients. And this was their data. Now, is there a role of adjuvant radiotherapy in the presence of multiple adverse pathological features? And this study from Amrita actually analyzed 144 patients, and what they found was adverse pathologic features were associated with local control, so far as the margin was 5 millimeter, infiltrative margin, depth more than 4 millimeter, lymphovascular invasion and perineural invasion. And they devised a scoring system, and anybody who had a score with more than 5 points had a 5-year local regional survival of less than 60%. And this was the kind of scoring system that they developed, depending on these adverse pathological features, that is a margin, tumor depth, infiltrative margin, poor differentiation, LBI, PNI, and those with margins over 5 millimeters had improved local control rates, and they found margins to be very important in their series at least. Now we at the Tata Memorial Hospital, together under the umbrella of the HLCOG, are doing this multicentric trial, which is going to enroll 392 patients, and I think of last that I heard, there are only 18 patients remaining to be accrued. And this is a study which is actually going to look at the role of adjuvant radiotherapy in the presence of these adverse features. The primary endpoint, of course, is locoregional recurrence-free survival. Now what dose? Typically the dose that we use would be around 60 gray, no point in dose escalation. The timing and overall treatment time, we should start as soon as the wound heals. Within 6 weeks of surgery, the overall treatment time should not exceed 89 days from the date of surgery. And of course, this has an implication. The total package treatment time should not be 90 days, and this predicted a worse overall survival, especially for high-risk patients receiving adjuvant CRT. That remains true even for patients who are receiving adjuvant RT alone. A few contentious issues about the role of adjuvant RT in N1 oral squamous cell carcinomas. This was an NCTB analysis, and what they found was about the patients that is enrolled between 2004 to 2014, 1,800 plus patients. with T1, 2 and N1 patients, median follow-up of almost 5 years, and what they found was the median survival was about 116 months. Adjuvant radiotherapy was received in about 1,100 patients, and on univariate analysis, RT was associated with improved overall survival for both PT1 as well as PT2 patients. Significant improvements in overall survival were there in the PT2 patients especially, but not for those with PT1 disease. Adjuvant radiation is associated with overall improved survival in the presence of PN1 disease without ENE, especially for the PT2 category and not so much for the PT1 category. Now there is other data also in this space, and post-op radiotherapy may be associated with improved survival in patients with PN1 oral cavity and oropharyngeal, especially in those who are younger and who have PT2 disease. Of late, we also have this study, which is a German prospective multicentric cohort study. And what they did find was that if you use adjuvant radiotherapy for the PT1, PN1 patients, there was definite improvement in the progression-free survival, but not so in the overall survival. But for the PT2, PN1 patients, there was a definite improvement even in the overall survival. And then there was also a higher toxicity in patients who received PT1, PN1. So hence, when you're thinking about adjuvant radiotherapy in this group of patients, we need to discuss each individual case, weigh the benefits versus the risks. Of course, the NCCN makes this space a little more murkier by adding systemic therapy to radiotherapy in the presence of these adverse features, but the evidence in this particular area is very sparse, and we don't usually do this, especially because we don't have evidence and also for considerations of toxicity. We have to remember toxicity to multimodality therapy whenever we are talking about intensifying treatment post-surgery, and this is important to keep in mind, because even if you look at the two seminal papers from RTOG and EOTC, there was a significant increase in the amount of toxicity with patients who received adjuvant CTRT. In conclusion, I'd like to say adjuvant radiotherapy improves post-operative local regional control in patients with early stage cancer in the presence of adverse features. However, it is essential to standardize the reporting guidelines for these parameters because there are differences in how a pathologist calls a particular entity what it is. Treatment intensification in the presence of above high-risk features should be weighed judiciously, whether they are there by themselves or in combination with other adverse features. And of course, further clinical validation of their impact is essential. Use of adjuvant radiotherapy has to be weighed in the light of disease-related outcomes and toxicity. Thank you very much.
Thank you so much, ma'am. That was truly a very, very enlightening talk and a lot of new points which was new for all of us and we learned it. Thank you. We shall now proceed on to the last part of this session, and that is a panel discussion. Now, the panel discussion's topic is locally advanced oral cancers. The moderator for this specific discussion is Dr. Hajdar, Consultant and Head, Department of Head and Neck Surgical Oncology and Skull-Based Surgery, Medica Cancer Hospital, Kolkata. Prior to passing on to the podium to him, may I request the panelists to kindly approach the bench. We have Dr. Kinshuk Chatterjee, Consultant, Department of Head and Neck Surgical Oncology, Medica Cancer Hospital, Kolkata. We have Dr. Gurucharan Sahu, Consultant, Department of Head and Neck Surgery, Tata Medical Center, Kolkata. Dr. Shreya Bhattacharya, Consultant, Department of Head and Neck Surgical Oncology, Narayana Super Speciality Hospital, Kolkata. Dr. Saidul Islam, Senior Consultant and Advisor, Department of Head and Neck Surgical Oncology, Medica Cancer Hospital, Kolkata. Dr. Sarvani Ghosh Lashkar, Professor, Radiation Oncology, TMH, Mumbai. We have Dr. Abhishek Chatterjee, Assistant Professor Radiation Oncology, TMH Mumbai. Dr. Kumar Prabhash, Professor and Head, sorry, he's not. Dr. Sudeep Das. Dr. Animesh Ghosh, Assistant Professor, Department of Otorhinolaryngology, Head and Neck Surgery, SSKM, IPG, MER, Kolkata.
Very good morning, and I think with such a star-studded panel, it's like a galaxy of stars. It has made the stage look small. But anyways, we are very lucky to have such an eminent list of oncologists here on this panel. We are thankful to Alken for sponsoring our session. Without further ado, we will go ahead. We will go ahead to the panel, and we like to make it as interactive as possible. This is a panel on locally advanced oral cancers. This is something that we see most commonly in our routine practice. And Sudeep is not visible, so we have to do something to make Dr. Sudeep visible. Maybe I can just take this podium a bit towards the side. Does that happen? Yes, that happens. Yes, and slowly you can see Sudeep appearing from behind the. I'll see you on response assessment scan. Is it? Nice. Thanks. So. Yes. Right. A lot of the topics have already been discussed. A lot of points have already been shared. So I would like to make it quite objective. Request the panelists to keep their answers as brief and as clear as possible, so that we send out a clear message to the audience. And we've got a lot of youngsters here, and I'm very happy that even on a Sunday we've got a fair deal of young crowd in our session. So I'll straight away go to the first case, which is a 26-year-old male, growth left buccal mucosa since 4 months, no known comorbidities, complete trismus. Examination shows a growth involving the left buccal mucosa, both the upper and lower GB sulcus involved. Rest of the extent could not be assessed on the clinical examination. The overlying skin was indurated, reaching the zygoma with impending ulceration with a palpable left 1B node. This is like the routine and the everyday variety of patient that we happen to encounter, unfortunately, in our OPDs. And the scan shows that the masticatory space, the ITF, was involved. Disease present in the retroantral space. The temporalis muscle fibers have been involved, and just to a few slices above the sigmoid notch to make it even a bit more interesting. The fat plane with the lateral pterygoid muscle was otherwise free, and the same findings were also, this is a CT, but we also did an MRI and confirmed the same findings. So the biopsy was moderately differentiated squamous cell CA, CT thorax was normal, T4BN1 M0, ITF involvement just above the sigmoid notch. I will start with the surgeons on the panel. So Dr. Shreya, what would you define this as? Is it resectable? Is it borderline resectable? Is it unresectable? What are your criteria for resectability and operability in oral cancer?
So this is a young patient with good performance status. I would deem this disease as borderline resectable in view of high ITF involvement and also the skin involvement above the zygomatic part. And I would probably think of downsizing tumor with the help of neoadjuvant chemotherapy and give him a trial so that after bioselection the patient does well.
Great,
we can
interesting.
surgically manage.
Right. Next, Dr.
Shamu, what is your opinion about this case? What would you define as operable and inoperable or resectable in your practice at TMC Kolkata? What is your approach?
I would completely agree with Dr. Shreya regarding the approach to the patient as he is young. I would definitely try for a curative intent, but after downstaging the tumor only, I would go for curative intent surgery, whether depending upon the chemo selection of the patient. One more thing I want to add, that in such an extensive tumors nearer to the skull base, in the MRI I would be looking at the nerve involvement, whether it is going into the through the nerve to the skull base and the foramina, so that in those cases I may not be considering upfront it is a curable, because there is high chances that the at the distant in a remote stage it may fail later.
Okay. Seeing on these scans, Dr. Kinshuk, if you see these scans here on the coronal, although it's mentioned that the disease does go a few slices above the 6-point notch, but we see that there is a good plane with the ITF, and probably with an upfront surgery you might get margins. So what would be your approach in this patient? Would you go the neoadjuvant chemotherapy way as Shreya and Dr. Shahu, or would you go for a surgery
for this case, although there is a clear margin, although there is a clear plane between the lateral pterygoid and the skull base, I'd still consider looking at the clinical picture of the patient, absolute trismus, and with induration reaching up to the zygoma. I'd still like to call it a borderline resectable. And given that the patient is of young age and good performance status, I like to give 2 cycles of NSCD, preferably
we'll just come to that. We've got a lot of senior faculty on the dais. Vikram sir, Prashant sir, what would be your approach?
So for this particular patient, I've got 2 things in mind. Many times you're looking at a scan, you feel it's operable and all that. One thing, you look at what is the date of the scan, how long previously it has been done. That's one thing. Another thing, I would like to get an MRI for this patient.
We did an MRI. Yeah, definitely we
so
did
that
an
MRI will definitely, and you want to rule out the PNI, because many times you miss the
Absolutely.
PNI on the
Absolutely.
So these are 2 things, how long before the scan has been done, you need a fresh imaging, you need an MRI.
Sure.
Take the call.
Vikram sir, your opinion on this patient? Right. Get sir a mic.
And I think the second point which Prashant was also trying to make out, many a times after surgery, these lesions turn out to be T2, T3s actually, and what involvement we are seeing is mostly in edema.
Right.
And I have personally a lot of problem in defining something borderline.
Right.
It is either resectable or it is not resectable.
Yes.
And as Kumar sir was also showing his data, only 40-45% of people who were deemed inoperable could undergo surgery.
Right.
So I agree in principle with the concept of bioselection, but as a surgeon, what you need to know is, can you operate with a clear margin or not?
Correct. So just to summarize what all our esteemed ma'am, yes ma'am.
See, the reason I agree with what Vikram is saying is that if you go back to your axial cuts, you also need to see whether there was any disease in the pterygomaxillary fissure.
True.
Because that is something that's going to be important for you. Because even if you've got response, what are you going to do at that particular area? Because then your soft tissue margins are questioned.
Correct.
And in the JC, we often push our surgeons to tell us, if there was response, will they really go ahead and operate? Only then is there a point in actually giving neoadjuvant chemotherapy. Because you give neoadjuvant chemotherapy, you spend about 2 to 3 weeks, 1.5 months or so. And then at the end of it, if the patient has not responded, as he said, 43% patients respond, the remaining don't. And only if you have that 43% response and they go on to have surgery, only then do those patients do well. So it's very important for the surgeon to take this call even upfront, I'm not a surgeon, but otherwise these patients are going to come for concurrent CTRT. I know they're not going to do well, but at the same time we need to understand whether it is worthwhile giving them the morbidity of surgery. So then it's important for the surgeon to take this call on day 1.
Very important points, ma'am. And just to summarize again for the youngsters here in the audience.
Harsh, can I make a point? Yeah. So I'll agree with the Sabani Vedal's point
So nowadays, when you look at the R series previously published and some more added to that, pterygomaxillary fissure is the area which we base our decision on all around, because that's the area where the PNI is going to be. You're going to fail in the foramen ovale and other structures.
Yes.
And even when you see a lot of patients, they are reported as coronoid tip is involved. So if you see the classical Leavata, it is supranotch, but they are not that bad if it's not a posterior based disease. So don't write them off. But yes, pterygomaxillary fissure should be, in our opinion, per se, that should be the criteria to like.
Right.
I think same issue, thing like Sarvani madam said. Only one point I want to emphasize here is that NACT, though we have to give, but our own series of Dr. Vijay Patil, and in our own experience also, we have to understand that up to 30 to 40% are going to be responders. There are going to be lot of patients which are going to progress. So please keep in mind, if it is operable, like already everyone discussed, we are getting a margin, we have to go surgical.
So it's generating a lot of questions. So thanks for that, Harsh. And the question of borderline resectable, I do agree, it generates a lot of controversy. It's a grey zone. It generates a lot of debate. But we need to keep in mind that in CA pancreas, there is clear-cut defined borderline resectable cancers in CA pancreas. Why not in CA oral cavity? So the point here is that I'm sure, the resectability is variable from surgeon to surgeon, but then we need to reach a consensus that not everything is resectable. There are borderline areas, and we need to, probably the existing definitions may not be clear to all, but then there are these groups which we need to identify. Probably we need to define them better.
So would you just like to elaborate for the audience and of course anybody in the on the stage as well, the difference between resectability and operability?
Harsh, you're taking a vibe off for me now. You caught me there, right?
No, sir.
See, the resectability might vary from surgeon to surgeon. It's like where the disease approaches and whether you're able to get an R0 dissection there. And whether the patient is fit for anesthesia and operable because of various other comorbidities and other things is a different issue altogether.
Right.
Now here we are talking about tumor-related factors alone, based on which we are trying to see whether the lesion is resectable or not. So it's not as what I would like to differ from what Vikram sir said, that it either is resectable or unresectable. If that was the case, I just gave an example of CA pancreas. In CA pancreas, there's no resectable or unresectable. There's something in between as borderline resectable as well. So perhaps in oral cavity also there exists one thing, but then of course these are debatable topics.
Harsh, I just want to answer your question.
So my problem is not with borderline resectability. It's perfectly fine. My problem is with individualizing it. If something is at TMC Kolkata borderline and it becomes operable in Bangalore, that is the problem I see. So similar to the TNM staging, I think we need to have this definitions of what is unresectable, what is borderline resectable, because it cannot be individual. That's my only problem.
Okay. I know.
So we are currently working on that. I totally agree with that. So what is unresectable in my opinion, if it is resectable with someone else, then there is a problem. The point here is the patient is at the end of the day, suffering the brunt of it. So probably we are working towards, reaching a consensus on that. Maybe sometime down the line, we probably will be in a better position than what we are right now.
Right.
I just wanted to answer this.
Yes, Shreya. And with that, I think we are going to kind of draw the curtain here.
Yeah, something may be technically resectable in terms of achieving margins all around, but operability also accounts with the appropriate reconstruction so that ultimately the patient can render a meaningful quality.
So you mean to say that every resectable tumor need not be operable, yes. Right? So that's the point that we are trying to drive home, especially for the youngsters here. We have some data coming in from, which is being generated from TMH, and there have been papers looking at the role of neoadjuvant chemotherapy from Dr. Prabhash and Dr. Patil's studies, that they have classified or defined something as borderline unresectable, supranotch tumors, disease going up to the zygoma, involvement near the hyoid, disease close to the vallicula have been kind of termed as, and of course extensive skin involvement as well, have been termed or brought together under a relatively subjective group of tumors known as borderline resectable or borderline operable. There are centers which offer neoadjuvant chemotherapy, but again, if you feel that for your patient, like for in this case, if one feels that yes, that there is not significant high ITF involvement, the pterygomaxillary fissure might be involved lower down, but the disease is not tracking up higher, the pterygopalatine fossa is free, there is no disease, there is no PNI or perineal spread near the foramen rotundum or the foramen valley, you can get like at least 5 millimeter to a centimeter margins at resection. Please go ahead with surgery, with upfront surgery. So this is a subjective debate. The debate is going to go on till we arrive at a consensus, but it is important for us to know that between purely operable and purely inoperable, there lies a gray zone. We may want to term it differently across our institutes, but the approach should be to provide cure wherever it is feasible. The important questions to ask is, can I resect with margins? Can I reconstruct appropriately? Can my patient have meaningful quality of life? So if these three boxes are checked, definitely go ahead with surgery. Otherwise, offer neoadjuvant chemotherapy, try to downsize, and then operate amongst them. Role of compartmental resection, and I'll come to Animishda. Animishda, we do a good deal of high ITF clearances. What would be your indications for doing a compartmental resection? And by compartmental dissection, what would you define that as? Right. Your mic is not on. Right.
So as long as it is in the lateral ITF or in the mastoid phase involvement, there is a chance to remove as a block and compartmental resection. But if it is involved high ITF, I should not go for compartmental resection.
What's your opinion, Dr. Kinshuk? What would be your definition of a compartmental resection? And
so compartmental resection is basically resection of the tumor along with all its potential pathways of spread, which can be via the muscles, which can be via the lymphatics and along the nerves. So for this kind of tumors, if the tumor is restricted to the low ITF, I like to clear the high ITF as well. So the concept is the tumor is restricted to a certain level, so we take the next level as the margin.
Right. So this came from, again, Vikram sir was definitely involved in the initial papers that came from Nirav sir's group, and we know compartmental resection to be resection of the entire masticatory space. It is a bialveolar resection where you take down the entire masticatory space from the skull base along with the part of the lateral pterygoid plates. Shreya, would you be operating any and every patient with of the lower alveolar involvement or involvement of the mandible? Would every patient in your book go for a compartmental resection, or do you have specific areas only when you would do? I mean, would you do soft tissue margin based resection, or would you do a compartmental for all your mandibular tumors?
So generally for stage 3, T4 lesions, I generally prefer to do a compartmental resection. Rather than seeing the tumor, I go all around the tumor.
Right.
So like to answer, in this case, probably you do an en bloc resection of the masticator space, the mandible, the upper alveolus, the middle lateral pterygoid, the pterygoid plates, and just a clean sweep over the lateral plate wing of the femur.
Right. We saw a very nice video demonstration of the compartmental resection by Shiva sir. Any tips or tricks, or do you take the mandibular cut first, you release the condyle first?
Shiv Kumar said, I think one of the most important thing is to ligate the maxillary artery
Absolutely.
Early on. Then sometimes when these patients they have bulky level 1B disease, it's good to take the en bloc 1B along with the thing, so that you don't ligate the facial artery at the lower border of the mandible rather than ligate the facial vessels at the origin, or leave a bit of a stump to the plastic surgeon.
Right.
Then sometimes because these patients have trismus, to get that high ITF fat clearance, I sometimes give the anterior cut and then pull the entire thing down. One more thing in Amrita we used to do, instead of removing the condyle, we will do a subcondylar osteotomy and retract the condyle up so that the lateral pterygoid margin clearance is a bit more.
Okay, great. Would ask Dr. Shahu, would you use a frozen section for assessing your soft tissue margins whenever you're doing a compartmental?
I would rather do a complete clearance rather than sending for a frozen section. I'll go hug the skull base in the cage and send it up to the foramen ovale. I'll go from one direction, and from the pterygoid plates I'll cut it along with that and remove the entire specimen from the skull base rather than sending it for a frozen section.
So like sometimes you have involvement of the higher fibers of the temporalis or even just above the insertion and all. Would you do you have a practice of inking that area and marking it for your pathologist?
Whenever I will be having a doubtful area of high ITF involvement in the form of retroenteral fat and temporalis muscle near that area, rather than I will go for a separate incision for the temporalis and drop it down from the temporal fossa so that the temporalis end block can be removed along with the tumor.
Okay, interesting point. Any comments about margin assessment during a compartmental resection? Floor.
So my policy is to always do a frozen section, and I would always ink whatever closest soft tissue margins, because that is where you as a surgeon are better oriented than the pathologist, as to where to look for the soft tissue margin. So that's one thing. Two small points that I follow during an ITF clearance. One is, like I think she said rightly, that anterior osteotomy, when you do the anterior mandibular osteotomy, you can swing the mandible anteriorly, you get a great access to the maxillary artery, you just continually apply a clips, and that will reduce your bleeding during the ITF clearance. One point that I always say, because many times it's the cut at the plates that's the most difficult, and sometimes blind if your tumor is right there in the sigmoid notch. So that's why sometimes we have navigation inside in our theaters. You can use it to just precisely be able to take that cut, because sometimes it can be very difficult, and it's only there where we most of people will make mistakes initially in our doing initial surgeries. We made mistakes. If that cut is low, and your some amount of pterygoid is going to be left behind, and that is why your surgery becomes messy. Your surgery is going to be beautiful if you go right up to the greater wing of the sphenoid, get the entire lateral pterygoid insertion there, and that's going to be a clean, nice job.
Just a small point for discussion. I recently happened to be in northern Italy, Brescia, and happened to observe how they do their compartmental resections, and contrary to what we believe, they do have a significant load of locally advanced mandibular tumors as well. And because that unit is so advanced endoscopically, so even for oral cavity tumors, they release the pterygoid plates high up through the endoscopic transmaxillary approach, release that, give the cuts, and then they do everything else as we normally do it. So although if you hear of it, it might seem a bit absurd, but having seen their resections, it was something new, something novel, something that can be tried, can be applied.
I think that's an excellent point, and also what that does is, you can take that cut endoscopically and just remove the pustular of maxilla and actually assess. That should be ideally the first step of your surgery.
Absolutely.
If you have done that and seen that the fat there is looking healthy and clean, you know that you're not dealing with a disease right up there, then you can proceed with your surgery.
Right. We are a bit short of time, so I'll just rush reconstruction. We have doyens of reconstruction in the hall today. I would start with Saidul sir. Sir, you told me not to ask you questions on resection, so I'm asking you questions on reconstruction only. So, sir, we've done a good compartmental resection, and I would want to know your algorithmic approach of your choice of reconstruction, bony, soft tissue, free versus medical.
For choice of flap, we need to understand that what is the outcome, what's the cost of quality of life. After these sorts of resection, the extensive soft tissue loss, he needs at least a oral lining and outer covering, and a deficit of bone for maxilla and mandible also. Now, if a free fibula or osseous reconstruction is done, where there is lots and lots of soft tissue deficit, what exactly happens? That overlying skin just simply get tethered to this fibular head, and patient develops severe trismus.
Patient will go for juventate as well.
Definitely, yeah. This patient definitely will go for adjuvant or at least Turkey.
Yes.
So definitely there will be severe trismus. So in considering that trismus, we shall go for a soft tissue only reconstruction. We have a good choice with anterolateral thigh flap. If it's perfect is the problem, we can go for a latissimus dorsi free flap or TDAP. Thoracodorsal perfect flap. And definitely radial foreign flap is not a good choice for us.
Absolutely.
If the patient is very young and is very keen to get a mandibular reconstruction, then what should we do? We need to prevent severe trismus, severe soft tissue tethering surrounding the reconstructed neomandibular mandibular fibula. We can go at fibula with another soft tissue flap. Definitely one fibula will not suffice for such type of reconstruction. So fibula for mandibular reconstruction, maxillary reconstruction not necessary, but may be done with a segment of fibula. And another free flap for inner lining, outer covering. These should also have a good muscle component, say anterolateral chimeric anterolateral thigh flap. But cutaneous component and one muscular component may be added with a separate perforator. The idea of this muscular component in the flap is to provide sufficient bulk surrounding this mandibular ramus region in the infratemporal fossa region. Obviously, this muscle will undergo disuse atrophy, no doubt. But by the time the patient will develop this disuse atrophy, he will have a sufficient amount of thing. So if you can put a reconstruction with composite and mandible free flap, then fibula can be accepted.
We'll go ahead to Anupam sir. Sir, you're here as a chairperson, but then we would definitely want your opinion as well for your choice of flaps in this kind of a case.
The choice of flaps will depend also on the prognosis. Like certain patients where we are expecting a good prognosis, younger patients, more expectations, we will go for double flap, like Dr. Islam said. We go for fibula for the mandible and another flap to provide the lining, inner, outer, and muscle to fill. So something like a ALT flap along with fibula. But most patients who have such advanced sections, prognosis is going to be guarded. So we would most of the time just get away with doing a ALT where we take a lot of vastus lateralised muscle with it, fill all the spaces, and provide the skin for the covers. So that would be my choice.
Any points to add, Sinjini? Would you want to add anything to what's being said?
So I totally agree with Golash sir, he's my mentor as well. So these patients need to be sent to adjuvant therapy as soon as possible. So you keep it simple, just fill the defect and send it up for adjuvant therapy.
And just try to make it a bit more interesting here. We have this, however, is.
Harsh, hi, could I just.
Please, how can I say no to you?
Okay, so we had just a lot of discussion about the compartment resection and tumor directed excision. Now, from PRS point of view, what I want to know is which one is better for you for the optimal reconstruction. We have both the options, we can follow both. So one is a compartment, we go right up to the skull base, take out all the pterygoid muscles, temporalis muscle, the condyle out, everything. We can see the bone out there. Is it more difficult to reconstruct compared to if we leave the cuff of the medial pterygoid, lateral pterygoid out there?
No. In a compartmental dissection, your medial pterygoid, lateral, everything is included in a surgical space where nothing is there basically. And for optimum reconstruction, a soft tissue flap is in 95% cases. In few cases, younger patients very much keen to get a mandible for cosmetic region, but some patient may say, sir, I may live for only 1 year, but with a good, better quality of life. For the selected cases only, you can go for a double free flap.
I just want to ask the opinion of our esteemed reconstructive surgeons here. This is a kind of tumor where you might be able to leave up a part of the ascending ramus and condyle. You might have to resect the entire masseter, the medial pterygoid, part of the lateral pterygoid. So what would be your choice? Would you go ahead, would you want me to resect the condyle and put in a soft tissue flap, or would you be happy doing a fibula? And what would be your expectation of trismus in this kind of a patient?
This is not a composite.
This is not a composite dissection. This is margin guided dissection. Yes.
The question is that is the patient is having an oral submucous fibrosis or not?
No.
Not oral submucous fibrosis. Okay, fine. So in this case, The condylar part, I mean, preservation of the condyle doesn't matter. Segmental resection of reconstruction from condyle to the canine region, even up to midline, even up to opposite angle, is possible with a single tool.
But will it be worth it? Will it be worth it in terms of mouth opening? What I want.
Definitely.
Shreya, you do reconstructions at times yourselves. What would be your opinion?
What's your question? Does this warrant a bony recon?
Would you do a bony recon if we are
age
able to
of the
save the
patient,
contact?
pre-op, trismus,
Young,
biology
40-year-old, no trismus, good mouth opening, no outer skin.
Yeah, so it's a lateral mandibular defect. Both options are viable. I will give the options to the patient, and then the patient opts for bony recon. I think that can be done. Obviously, during the resection part, it's easier for the recon surgeon if you keep a condyle stump for us to plate it. Otherwise, you have to do a gap arthroplasty.
Vikram sir, you didn't seem very happy. Would you want to add anything?
No, in fact, I completely agree with. One of the thing is the soft tissue has to be given due importance. It's a large cavity being created, and as both the plastic surgeons pointed out, it's very important. But I think as a whole, we have this preconception that mandible should not be reconstructed. I think that's not a right thing. We have to put this mandibular reconstruction option on the table for the patient.
Exactly.
And it is for the patient to decide. For far too long, we have not respected mandible and bony reconstruction. I think it needs to come back with the caveat that the soft tissue takes the more importance, because otherwise just putting a bone is of no good.
Sharmani ma'am?
Sorry, if the external skin, there's no external skin defect, that is again a favorable point.
Right. But if there is external skin, then what would you do? Or would you do a double flap there? Okay. Sharmani ma'am, I wanted to know your opinion. You've been in TMH for so many years. You've seen a lot of outcomes of resection. We have this preconceived notion in TMH, as in, at least when we were studying that, do fibulas for the selected anterior mid-thirds. Whenever there's a lateral kind of a defect, put in a soft tissue flap, because if you put in a fibula, there's going to be trismus. Ma'am, your opinion as a radiation oncologist.
See, what I really like these surgeons, and that's what I keep telling every time, is I want adequate soft tissue. It would be best for you to be able to reconstruct like with like, do the bony reconstruction, but please give adequate soft tissue cover, because tomorrow after radiotherapy, you invariably blame the radiation for having caused the necrosis or the extrusion of the strut. But that's not the reason why it happens. It happens because there is inadequate soft tissue cover. So whatever you do, please give us adequate soft tissue. Yes, I know that plastic surgeons are not very happy with the radiation oncologists, because post radiotherapy there is a loss of the volume. But that's something that's going to happen. And we do need to give adjuvant radiotherapy, because otherwise the patient is going to come back, especially in a case like this, is going to come back with disease. But we need adequate soft tissue cover to prevent the sequelae.
The provision of adequate soft tissue is utmost important. It's very, very important. That is the question of double free flap.
Exactly.
Because fibula is definitely very good for the bone, but not at all good for soft tissue reconstruction.
Right.
So you need to add one extra flap, say ALT flap or something else.
But while it's, yes, becomes a.
Sharbani is talking more like a surgeon, so I want to ask her, is there a way where you can exclude the flap from your plan?
I keep getting asked this question by Dr. Toprani also. So the thing is that what happens is we don't intentionally cover the flap. By that what I mean is that the target volume in the adjuvant radiotherapy is the tumor bed. So typically when we are planning with IMRT, we fuse the pre-op scans with the post-operative planning CT scan. In that, whatever comes, we include, okay, as the target bed. But what is very important is the soft tissue, flap, anastomosis area, because that's where is the cut margin. So that is something that definitely has to be covered with radiotherapy. There are some 2 or 3 articles that have actually, Harsh is showing that one of them. So it's very important to actually cover that area when you're including in your target volumes. But you don't need to go after the flap. You need to go to the tumor bed and you need to cover this junction, which is very important.
Abhishek, you're also, I know you do neuroradiation predominantly right now, but then as a head neck radiation oncologist, what would be your GTV with respect to a patient reconstructing the flap and the need for standardized guidelines for flap radiation? Because oftentimes we see most of our recurrences are at the flap and the native tissue junction. A lot of our recurrences are in that area. So is it something to do with the radiation delivery, the radiation protocols? Your opinion on it?
I think what Madam pointed out, don't intentionally take the flap, but don't really try to leave out the high-risk areas.
Yeah.
And the problem with all these guidelines is they are consensus-based. There is no objective metric by which you get these guidelines.
Ma'am, we had this discussion a few months back when we had that panel in Max, Bombay. And then you had mentioned that you were part of the initial questionnaire that led to this paper. So the junction of the flap and say the native bone, that is where the surgeon would have taken his margin. So wouldn't the margin anyways be a part of your radiation delivery protocol, your portal?
Yeah, so now over time I've also learned one thing. When you typically get those stump recurrences, that's for that particular reason that you've not really gone beyond the surgeon's margin. Because some people tend to tell you that post-op, the volumes become smaller, but they don't become smaller because your clinical target volume will actually encompass things that are actually in the area or under the purview of what you could talk as microscopic disease, because the surgeon has gone in, removed all visible disease. But we need to keep in account the fact that this is a contaminated area. We need to go beyond that. And this is especially true when you have extensive soft tissue involvement, when you have nodes with extensive nodal with extranodal extension. So these are things that you have to keep in mind, and especially if the other question is when you use these flaps, the other flaps that traverse the neck, your PMMCs.
Yes.
So, and if they traverse the neck through areas that have had extensive nodal disease with ENE, you need to pay a little bit more attention in those areas. So what I mean by saying is don't go after the flap, but at the same time don't compromise on what you need to compromise to treat the disease adequately. That's my point. So
I think Vikram Sahai was spot on in anticipating your question and putting this slide in. We'll just go back to another case, CA tongue. I'm sorry, it's a few cases behind. Right. So this is again 38-year-old male, extensive tongue involvement of the sublingual space. On scans, the disease was about 7 to 8 millimeters away from the hyoid bone. Kinshuk, start with you. What would be your resection plan? When would you do a compartmental excision for tongue? So just like we have compartmental excision for the gingival sulcus tumors, we have compartmental excision for the tongue as well. How would you approach this case? What resection would you do?
So compartmental resection of tongue, I like to reserve only for patients in whom there is involvement of the floor mouth with involvement of the mylohyoid. So be it T3, T4 or T1, T2. Often we find T1, T2 tumors which are a little infiltrative and goes deep into the muscles and comes closer to the mylohyoid. So for these patients, I reserve a compartmental resection. Otherwise, I go the wide excision.
Dr. Shah, what would be your indications, your plan? Suppose I just mix it up here and say that this is not as infiltrative as this, but just stops above the sublingual space. So for example, so in this normal site, suppose this is a sublingual gland, the disease just stops short of it. Would you do transoral excision with adequate margins, or would you want to take the entire sublingual space sort of more compartmental for this kind of patient?
So I would like to know also the mouth opening of the patient. If the patient
very
is
good
having
mouth
very
opening.
good
You
mouth
can see his
opening,
epiglottis.
and it is easily accessible that all around supple I can get the mucosal margins, then I would
So I'm saying for a patient who has good mouth opening, you can still get good margins all around, but therein, would you do a compartmental, even if it is just near about the sublingual space, or would you do a transoral margin guided excision?
I would do it in a case of tongue tumor. I would not take a risk, and I would do a compartmental resection in a case of tongue if it is just abutting the sublingual space as well, and I would try to remove that side compartment for the tongue tumors.
Any particular reason why you want to do that?
Because the soft tissue clearance, because for the tongue it is the soft tissue clearance around the tongue is very important in case of tongue tumors, where the pathways of spread from the tongue tumor is least resistant in certain cases, and because it is soft tissue structure there is no barrier, so it can go beyond our naked eye, so high chance that I can go through it.
Shreya, what would be your approach? When would you do a compartmental excision? Generally.
So, like Ishu said, fluoroform involvement. Like for me, MRI is very important. And see the involvement of the sublingual space, and as long as the disease is, even if averting the myelohyoid sling, I will go for a compartmental resection, not paroral. Probably in this case, we'll do a visor and a drop down in the neck. Reason is, of course, we have papers, literature to support Calabrese paper and various other retrospectives also, which have reported improved outcomes both in terms of disease.
Calabrese's paper have gotten even for T1 or T1, T2 as well.
I'm not going to do it for T1. Yeah. I'm just talking about what I would do. But then I do have some literature to support.
Any opinion from the floor? Opinions regarding compartmental excision of tongue? Dr. Kapila?
Just a couple of points I would like to make. One is that clinical assessment is of paramount importance, number one. Number two is that, you were saying just up to the sublingual gland and all that. So whenever the sublingual gland is aborted or something, you better do a compartment, okay? Because per only getting margins there, 1.5 centimeters soft tissue, you're going to struggle a little bit. Rather you just go through, it's lateral pull through, it should be a very convenient thing to do. And the last thing that I've seen literature where, many times when you remove the specimen of the tongue, you palpate, you had put margins all around the tumor, but the PNI along the lingual nerve, you'll find a cord-like thickening you'll find. That's number one. Number two, there's literature to suggest that there are multiple lymph node areas along the lingual nerve, neurovascular bundle. So actually many times it's not the PNI, it's actually nodal involvement there. So these are the places where compartment clearance works much better.
Just a word about this compartmental resection. Of course, this stems from the Calabrese, the Italian group study, wherein we recently heard PHS say that you do compartmental resection for a T1 tongue as well.
DOI more than 10 millimeters, they tend to do a compartment.
So that is T3 they say. Depth of incision more than 3 centimeters is fair enough. But then anything lesser than that, the message should not be that anything lesser than that we can go ahead with a compartmental resection. That is probably too much of tongue being there. Just because I can do a free flap, I cannot resect as much of tongue and put a free flap there. No, free flap is not replacement for a tongue. We are just filling the defect. So free flap cannot help the tongue to cannot make it mobile. The remaining tongue will help the flap move, but the flap cannot help the tongue move or have its routine function. So that's the point to be kept in mind. Just because I can do a free flap, I cannot resect everything.
We have a Tamil saying is coming to mind. We'll discuss it later during lunch. Vikram sir, any final points on that?
I would completely agree with Shiva in that. See, unlike the ITF clearance, where leaving few fibers here and there of median lateral pterygoid have no functional consequence. But tongue is a very dynamic structure. You remove only what is adequate for your complete oncological clearance, because the remaining tongue function is going to be of paramount importance for post-op rehabilitation.
Right. So we'll come down to indications for adjuvant treatment. Abhishek, would you just try to enumerate for the benefit of the youngsters, when would you give adjuvant radiation? When would you intensify treatment in oral cancer?
So essentially, it's locally advanced primary and multiple nodes, and adverse additional pathological factors like poor differentiation and perineural indication. When you add on the chemo, classically two indications: one is positive margins and multiple nodes with E&E.
Right. Sudeep, sorry for, I hope you've enjoyed a little snooze right over here, but then would you want to add adjuvant chemotherapy even when I've resected a tongue and my margins are around 4 millimeters? close margins or 3 millimeters? Or would you give adjuvant chemo only for a positive margin?
We recommend adjuvant use of concurrent cisplatin only the indications, two indications which are actually supported by Barnier and Cooper analysis. So positive margin and extra nodal extension. So these are the two indications where we offer adjuvant cisplatin. And now suppose the cases you are discussing throughout, those cases are very high risk cases. Young patients, extensive surgery was done, and I think in such cases, even though the post-op histopath is not showing any positive margin is free, still the patient who receive neoadjuvant chemotherapy particularly, in such cases, I want to treat them very aggressively and I will offer them concurrent cisplatin with the adjuvant radiotherapy because they receive neoadjuvant chemotherapy.
Okay. Regarding neoadjuvant chemotherapy, just although we're discussing adjuvant, but in NACT, briefly, what would be your protocol? Do you believe in the in a lesser dose modification to limit toxicity, like many people use a modified DCF regimen, or would you give the standard doses?
No. See, whether to give neoadjuvant chemotherapy or not, that I believe that is a purely call of a surgical oncologist, head and neck surgical oncologist.
Don't say that here. We do tumor board in our institute.
Yes.
Don't say that.
Yes. Okay, but so what is the intent of neoadjuvant chemotherapy? The intent is purely downstaging the tumor, make it operable. Because in oral cavity cancers, the understanding is surgery is the best chance for that patient. So then I need to consider that which regimen will achieve maximum downstaging, and our experience and as well as the data is available. It is 3-drug regimen: TPF, taxane, cisplatin, and 5-FU, and that is the standard 5-day regimen. That's there should not be any modification. If he is not fit for 3-drug regimen for 5 days, I will say probably he will not become resectable, and the intent of treatment.
What about doublet regimen? The paper has shown that you do get meaningful response even with the doublet regimen. May not be as good as the triplet regimen, but
not as good but in such cases, what Sharvani madam was telling, why not to try when you know that the operability, the potential is very compromised? Why don't you offer them upfront CTR in such cases?
Okay, you're opening up a Pandora's box here. I will just to make it simple. So, neoadjuvant chemotherapy, wherever you've given neoadjuvant and there's been decent response, we would want to add chemotherapy to the adjuvant armamentarium, even if there are no classical features like positive margins and ECS. We are quite on time, so I'll just ask Sharvani ma'am to sum up with the OCAT trial, ma'am, your results and what were the salient findings.
So the OCAT trial was essentially a trial that was looking at intensified treatment in the adjuvant setting for patients who had possible high-risk features. So what we found was that it was only in patients who had a combination of parameters like T3, T4 disease, N2-3 disease by the 7th edition, and extracapsular extension together were the ones who benefited from intensification of treatment. There was no advantage of giving intensified treatment for any other group of patients, at least so far as the OCAT trial was considered. But what you also have to remember is that the OCAT trial is essentially a trial that has hardly any positive cut margins. The cut margin positivity rate was only 1.7% of 1.7%. And the other thing is, though 50%, above 50% of our patients had extracapsular spread in their nodes, the median lymph node involvement was only 1. So these are some things that you need to understand as far as the OCAT trial is concerned. So I think it itself reiterates what the RTOG and the URTC trials tell us, that extracapsular extension positivity, cut margin positivity. We don't know about cut margin positivity, but extracapsular spread definitely is important, and that merits consideration. But just responding to something that Sudeep said, yes, in the cases that Harsh showed us, we would and we generally do treat with adjuvant CTRT. But there are other cases where we may not choose to do adjuvant CTRT depending upon the pathological response and the pre-op stage of the disease. Because there is actually no evidence in this area. Whatever evidence is available is for a completely different kind of patient population, the Licitra trial or the JANG trial. They're all in a different population of patients, and of course the mandibular preservation study. So these are things that I think we should keep in mind, because the toxicity of adding therapies, it's not only I'm talking about chemotherapy, but even radiotherapy or radiotherapy plus chemotherapy is considerable.
Right, so we don't have too much time for recurrent, but I would definitely say that we've had a wonderful discussion. We've discussed a lot of points, and I'm really thankful to my panelists, all of y'all, people from the floor. Big round of applause. I hope it's been a good discussion. Thank you so much. Thank you so much. And thank you every one of you for being part of this conference. On behalf of Team Medica Oncology, I think we are signing off with this session. So really great to have all of you. Thank you.
Okay, firstly, regarding the Patel-Sir's paper, where we discuss about one of the indications being peritumoral edema reaching up to the zygoma. Now that is more of something in that probably imaging-wise we may be high ITF, may be free, but it is more of a clinical judgment. So is it something that I would like to take the panel's opinion as well, as whether we would just rely on the clinical judgment on that and go ahead with the NACT and plan for surgery?
I think that's going to be a decision that you're going to take in combination with the clinical findings and your radiology. But oftentimes what we normally in our practice go for is there's induration going up to the zygoma. Classically, if there is purely edema, I would definitely want to give antibiotics and anti-inflammatory for at least 5 to 7 days, wait to see if that edema regresses, and then probably take a decision. Is discussion open to the floor? Anybody wants to take that?
Yeah, so it's a judgment based on clinical findings and radiology. So if it's a like what Harsh sir told, if it's an edema, I will also like to give antibiotics and anti-inflammatory for at least 7 days. We'll assess if that regresses or not. If that doesn't regress, that may be because of a peritumoral edema. In that case, I'd like to go for NSCT because the soft tissue resection will be extensive. And with an extensive soft tissue resection, the reconstruction options, like even if we have a free flap at our hand, there's no point like excising more of the soft tissue and giving a big bulk of free flap. Rather, I like to downsize the tumor, the peritumoral edema with NSCT, assess and then go for surgery. So it's a clinical and radiological judgment taken together.
Shatadru, what you need to understand is that the reason I think the surgeon doesn't want to do surgery in that case is not because it is unresectable, but because of the fact that if there is so much of dermal lymphatic involvement, you really do not know whether you're going to cut through disease or not. So you want to play safe, give the neoadjuvant chemotherapy, downsize the tumor to achieve negative resection margins, and then do your surgery. I think I take that as the reason, because that is what introduces a lot of subjectivity in your decision to do surgery.
And the second one being, sir, you asked that question regarding giving adjuvant chemotherapy along with radiotherapy in probably a 3 mm margin. So we are basing all our ideas on the Bernier-Cooper paper, but correct me if I am wrong, I think in both the papers that definition was different.
It was different.
So
that is
would
why,
it, so
that's why there's always a debate, because some centers would go ahead with adding adjuvant chemo even for closed margins, but then you need to know, the surgeon needs to be confident of what margins he has taken. If it is something like 1 or 2 millimeters, we may want to consider as positive. Something like 4 millimeters, we may want to do without the toxicity of chemotherapy.
Thank you so much.
Thank you everyone. Please stay back for request our chairpersons to kindly come forth and felicitate our speakers. Anupam Gulas sir, would request Anupam sir to kindly felicitate the all the panelists, starting with Olimishna. Claps please. I know it's the end of the day, the last panel, but then we can still put our hands together. Next followed by Abhishek. Abhishek. Thank you, Abhishek. It's great having you. Very dear Sharbani ma'am. It's so lovely to have ma'am on the panel. It's almost as if having an extra surgeon. Would like to request Sadal sir to kindly come forward. And this moment makes for a great pick. Shreya, great to have you. Next, Dr. Shahu, Dr. Guruchan Shahu. Big hand. Dr. Kinshuk Chatterjee. Lastly, Dr. Sudeep Gupta. Dr. Sudeep Das, sorry, not Gupta. I would request Doipanda to kindly come forward and do the felicitation of the previous speaker, starting with Vikram sir. His panelists, Dr. Dr. Joshi ma'am, Dr. Poonam Joshi, Dr. Manish, Dr. Poonam ma'am. Manish is here. Big hand. So great to have you, Poonam ma'am, here. Dr. Manish Goswami. We have Dr. Shatadru Roy. Dr. Vaibhav Singh. Great to have you, Vaibhav. Dr. Manu Matthew. Shiva sir is also. Dr. Kapila Manikantan. Dr. Shiva Kumar Tyagarajan. Great to have you, sir. Dr. Subbalakshmi Sengupta. Our oncopathologist, somebody whom we trouble and rely on daily and fight for reports. Thank you so much. I hope I haven't missed anyone. Right, I would request Vikram Keptakure sir to kindly come forward and felicitate our two chairpersons. Dr. Anupam Gular sir. Thank you so much, sir, for being here. It's been a great honor. And Dr. Doipan Mukherjee. Thank you, everyone. With that, I would photograph. Yes. We can all come and have a photograph if we have time. Yeah.